Cop in non-sticky hair oil.
Hello guys, am I visible? Just checking the things. Hello guys, am I audible and visible? Is everything clear? Okay. Okay guys, sorry for the delay. We got almost just 10-15 minutes. Okay, that's fine. So now in this class, we are going to have a rapid revision of physiology for the FMGE June. Okay, so for the FMGE, the July session of 2023, so we are going to have the rapid revision of the physiology, and this rapid revision is going to be done in two parts. This is the part 1, and there will be a part 2 also. So in this rapid revision, our main concentration, my main concentration is that you should never miss a single MCQ. Okay, you should never miss a single MCQ, and that's our target. So now in this today's class, let's go by system wise. We'll start with the cardiovascular system, and in this cardiovascular system, what are the important topics that you should know? Okay, I'm mainly concentrating on those topics where the questions are being asked. At the end of the day, this rapid revision should bring you as many questions as possible from the physiology point of view. Okay, so that's our target. Now, if you have any doubts, if you are getting any queries, you can always post it in the comment section. I will likely to answer your questions in the middle way because it will disturb the flow. So having said that, without any late, let's begin our session. Now, guys, we are starting with the cardiovascular system. In this cardiovascular system, the first thing which I want you to know is the action potentials. The action potentials of what? The action potentials of SA node and the ventricular myocytes. Okay, look here. Here I am showing you the SA nodal action potential, the pacemaker. The SA node is a pacemaker, right? We know it controls the heart rate. Now, the first question which I want you to know is, so this SA node is a pacemaker. Why it is a pacemaker? Even AV node can act as a pacemaker, bundle of his can act as a pacemaker, and the Purkinje fibers can act as a pacemaker. Okay, so why only SA node is the pacemaker but not the AV node? Because SA node right here produces maximum action potentials in a minute. Okay, so maximum frequency, that's the important point. SA node is a pacemaker because it produces maximum frequency of the action potentials. Okay, almost 60 to 100 action potentials will be produced by the SA node. So the entire heart rate is under the control of the SA node. Okay, now if you look at the action potential graph here, okay, this is the SA nodal action potential graph. Don't confuse. See, the resting membrane potential, this is the MCQ. What is the resting membrane potential of the SA node? The resting membrane potential of the SA node is minus 60 millivolts MCQ. This is the MCQ. Okay, so the SA node, the resting membrane potential is minus 60. And do you think it's going to stay minus 60 all the time? No, definitely not. This is the pacemaker cell, self-depolarizing, self-activating. So it doesn't stay at minus 60 all the time. Now what will happen? So from minus 60, it is going to little positivity. From minus 60, it is going to minus 50, minus 40, something like that. So look here, from here minus 60, okay, let's take this value, this is the starting point. Now look here, it is moving towards, see, it is moving towards minus 40. Okay, this is the minus 40, right? See, this is the minus 40. So now the point which I want you to know is, so what is this phase called as? This orange color line which I am depicting, what is this called as? See, the resting membrane potential is moving towards minus 40. This graph is called as, this phase of this graph is called as the prepotential. Okay, so this is called as prepotential, also called as pacemaker potential. Okay, pacemaker potential or prepotential. And it is also called as, one more name, restless membrane potential. Why? Because it's not resting. It's not resting at minus 60. It is going from minus 60 to minus 50, minus 50 to minus 40. So this is also called as restless membrane potential. So now the question which will come in your exam is, so this pre-potential is due to, or the restless membrane potential, or this pacemaker potential, this part of this graph, it is due to what? It is due to influx of, okay, it's due to influx of sodium ions as well as calcium ions also. Later I will tell you. So the first point which I want you to know is, sir, this pre-potential phase, this orange color phase, this pre-potential phase, it is due to what? This pre-potential phase is due to influx of sodium as well as calcium. That's the MCQ. Okay. So, okay, done. Threshold potential is attained. Minus 40 is attained. Okay. So, minus 40, yes, it is attained. This level. Okay, it's attained. Now, what is the next phase which was shown in the graph? The next phase which was shown in the graph is in red color. Okay. Are you able to appreciate? Look here. This is the red color. See, now this red color phase is called as the depolarization. So, depolarization means activation. The cell is getting into positivity. Now, this depolarization in SA node, the SA nodal cell activation, the depolarization, it is due to what? It is due to influx of calcium ions. Okay. So, this depolarization, it is due to rapid influx of calcium ions. Now, some students will get it out. Pre-potential is due to sodium as well as calcium. Okay, but important point is, now let me tell you here, see in pre-potential, okay, in pre-potential, both sodium is coming into the cell as well as calcium is coming into the cell. But this calcium is coming via T-type calcium channels. So that calcium is coming via the T-type calcium channels, T for transient, for little time, only little amount of calcium will come via the T-type calcium channels. And if you ask me one more important MCQ, this sodium is coming via which channels? The sodium entry into the SA nodal cell, the sodium will come via which channels, they will ask you. During pre-potential, sodium is coming into the cell via which channels? Via leaky or funny, are also called as IF. Okay, leaky sodium channels, funny sodium channels, or IF channels. So, sodium is coming into the cell during pre-potential via leaky sodium channels. Calcium is coming into the cell during pre-potential via the T-type calcium channels. But look here, this is the depolarization which I am showing you in yellow color. Okay, so this depolarization is due to influx of calcium via L-type calcium channels. Okay, see now I am writing about the phase of depolarization. So depolarization, it is due to influx of calcium again, but via which channels? Via L-type. Okay, via L-type calcium channels. Okay, done. After depolarization, what is the next phase? The next phase is the repolarization. See this blue one coming down. Okay, the blue color curve which is coming down, this part of the graph. So this is called as a repolarization. And what is, why this repolarization? Repolarization means inactivation, coming back to resting membrane potential. So this repolarization, it is due to potassium efflux. Don't forget, it's the outflux or efflux. Efflux of potassium ions will cause the repolarization. Guys, again, I am telling you here, I am not going to explain you in detail. This is not the time to go in detail explanation. Here, our major target is, in a limited amount of time, let's complete as many important topics as possible. So at the end of the day, this one session should give you all the MCQs. Okay, that's the target. So remember, in SA nodal action potential, 3 phases are there. One is restless membrane potential due to sodium and calcium influx. Second one is the depolarization. Depolarization is due to influx of calcium via L-type calcium channels, and repolarization is due to efflux of potassium. Done. Okay. But sometimes they can change the names. So this depolarization is also called as phase 0. Okay, depolarization is also called as a phase 0, and a repolarization. Okay, this repolarization is also called as phase 3. Okay, phase 3. So depolarization is all the time phase 0. Repolarization is also called as a phase 3. So that's it. Done. Okay. Now after SA nodal action potential, now let's discuss about the ventricular myocyte action potential. Ventricular myocyte, the ventricular muscle. So what happens in this ventricular muscle? How, it's going to have its action potential, the depolarization and the repolarization. Now, look here. See, this is a muscle cell, right? This is the muscle. So do you think muscles can undergo self-depolarization, self-activation? No. So they are all the time relaxed. Okay, they are all the time relaxed. But when you stimulate them, yes, they will undergo depolarization and later they will undergo contraction. Okay, so what is the resting membrane? It's all the time resting. The muscles are resting. When you stimulate them, they will undergo depolarization followed by contraction. Okay, so the resting membrane potential MCQ is minus 90 millivolts. So RMP of a ventricular myocyte is minus 90 millivolts. When you stimulate them, what will happen? Depolarization. Okay, depolarization means activation. The cell is getting into positivity. So the next phase which I am showing you here in this green color curve, this is the depolarization. You also know this depolarization is also called as a phase 0. Depolarization is also called as a phase 0. And this depolarization is due to what? This depolarization is due to influx of sodium or calcium. See, in SA node, don't forget, in SA node, the depolarization is due to influx of calcium. But here look, in ventricular myocyte, right now I am talking about the ventricular muscle. In this ventricular myocyte, the depolarization is due to influx of sodium. It's due to sodium influx. MCQ, depolarization is sodium dependent. After this, next point which I want you to know is after depolarization, any cell will undergo repolarization, inactivation, like relaxation, right? So now see, cell is undergoing repolarization. See, this is the phase 1. Cell start to undergo repolarization. So phase 1 is early repolarization. But do you know something what happens now? See, during repolarization is potassium is going out. Okay, potassium is going out. But do you know something what happens? This is the question which came in NEET PG 2023 exam. NEET PG 2023 exam, I think, which happened almost 120 like days back, I think. See, now when the repolarization is happening, potassium is going out, but at the same time, do you know, calcium will start to come into the cell. So positive ions are going out of the cell, K plus is going out of the cell. At the same time, what is happening? Calcium is coming into the cell. So efflux of potassium is balanced by influx of calcium. So do you think there will be any change in resting membrane potential? Now the membrane potential, do you think any change will be there? No, it's going to be constant. It's like a plateau. Okay. So now please look here. This phase is called as a plateau, also called as a phase 2. Now what is the important point? In this phase 2 or plateau, there is a calcium influx which is balanced by potassium efflux. Okay, they will ask you in plateau phase what is happening? Calcium influx balanced by potassium efflux. That's it. Now after that what happens? Repolarization. After some times the calcium influx decreases, the calcium influx decreases, potassium efflux continues, so that there is repolarization again. So again phase 3 repolarization is due to efflux of potassium. Okay, let's sum it up. Now tell me guys, the ventricular myocyte, the ventricular muscle. Now what is the resting membrane potential of the ventricular myocyte? Minus 90 millivolts. When you stimulate, depolarization will occur. Depolarization is also called as a phase 0, dependent on sodium influx. After depolarization, what do we have? Repolarization. But during repolarization, there is a phase called as a plateau phase, phase 2 or a plateau, where calcium influx is balanced by potassium efflux. Okay. After that, there is phase 3 or repolarization. Done. Okay, the 2 important topics completed. Now after this, what else you should know in cardiovascular system? The most important, the question which was asked in FMGE exam as well as the NEET PG exam, the last FMGE and last NEET PG exam, this question has been asked. The question is, S2 heart sound is heard during NEET PG exam. This was the question. S2 heart sound is heard during when? And S1 heart sound, S3, S4, these heart sounds are heard during. So here, as we don't have much time, let me tell you some basics. Okay, see the systole. Okay, the systole, the heart contraction, the systole. Mainly I am talking about the ventricles, not the atria. We are not concerned about the atria. When I am talking about the heart contraction relaxation, we are mainly concerned about the ventricles. Okay, so systole means contraction. How many phases are there in the systole? See, in the systole, there are 3 phases. One is isovolumetric contraction, rapid ejection phase, slow ejection phase. 3 phases are there. So in systole, there are 3 phases. How many phases are there in the diastole? See, in the diastole, there are 5 phases present. Okay, what are these 5 phases called as? Protodiastole, isovolumetric relaxation, rapid ventricular filling, and rapid ventricular filling, diastasis, and atrial systole. These are the 5 phases. Okay, so again I am highlighting. See, don't worry about the PDF. PDF will be uploaded in the Telegram group. You don't worry about the PDF. Okay, PDF you will get. So what are the 3 phases in the systole? Isovolumetric contraction, rapid ejection phase, slow ejection phase. Systolic phases are completed. What are the 5 phases of the diastole? The 5 phases of the diastole are protodiastole, isovolumetric relaxation, rapid ventricular filling, and rapid ventricular filling, diastasis, and atrial systole. These are the 5 phases of diastole. Now, what they will ask you the questions? Sir, S1 heart sound, it is due to what? Okay, you will hear S1 and S2 heart sound, say lub dub. Okay, this is S1 and S2 heart sound. So this S1 and S2 heart sound, they are due to what? Why we can hear this S1 and S2 heart sounds? Okay, for you to understand, I am just showing you the heart in a simple way. You already know this. Now look here, this is the 4 chambers of the heart. These are the 4 chambers of the heart. Now this is the right side of the heart. This is the left side of the heart. This is right atrium, right ventricle, and left ventricle. Now please tell me, what are these walls which are present over here? What is this wall which is present over here? What is this wall? This is the tricuspid wall. And what is this wall which is present over here? This is the mitral wall. Okay, this is the mitral wall. And what is this blood vessel which is coming out of the left ventricle? It is the aorta. And what is this blood vessel that is coming out of the right ventricle? This is the pulmonary trunk. Pulmonary trunk. The blood is going to the lungs. Now what is this wall which is present over here? This wall which is present over here. So this wall which is there over here is the aortic wall. This is the aortic wall. And what is this wall which is present over here? This wall which is present over here is the pulmonary wall. Okay, aortic wall and pulmonic wall. The semilunar walls. Now question is, why S1 heart sound? S1 heart sound is due to, it's a closure of mitral and tricuspid wall. This wall, this is the mitral wall. Okay, let me write here. This is the mitral wall and this is the tricuspid wall. Closure of mitral valve and tricuspid wall. Yeah, here. See, the closure of tricuspid valve and mitral valve, whenever they close, okay, whenever these valves closes, then it will cause a heart sound called as S1 heart sound. So that's why here also I have shown you, please look here. See, this S1 heart sound, this is due to closure of M1 and T1, mitral valve and tricuspid valve, they will close and causes the S1 heart sound. Okay, but question is, when S1 heart sound is heard, during which phase? Look here in the timeline diagram, in this time graph, in this entire time graph, please look and tell me. Sir, S1 heart sound is heard in the beginning, of the isovolumetric contraction. In the beginning of the isovolumetric contraction, there is S1 heart sound. Okay, so S1 heart sound is due to closure of mitral valve and tricuspid valve, and it is heard during beginning of the isovolumetric contraction. Completed. Now next question. Sir, why the hell is this S2 heart sound is there? Why S2 heart sound? Sir, S2 heart sound is due to closure of aortic valve and pulmonic valve. Whenever the aortic valve and pulmonic valve, whenever they close, they causes the second heart sound, S2 heart sound. And when S2 heart sound is heard, you look at this time diagram and tell me when S2 heart sound is heard. See, the best answer is S2 heart sound is heard during protodiastole, remember. Okay, see this S2 heart sound due to closure of aortic valve and pulmonic valve, A2, P2, aortic valve closes and pulmonic valve closes. So closure of A2 and P2 will cause the S2 heart sound, and S2 heart sound is heard during protodiastole. But in some of the exams, the protodiastole answer, like, if the option is not there, then you have to pick up which phase. Then you have to pick up the next best phase is isovolumetric relaxation. See, in the isovolumetric relaxation, or you can say in the beginning of the isovolumetric relaxation. Okay, so S1 is heard during isovolumetric contraction and S2 is heard during protodiastole. If protodiastole is not there in the option, then go with the isovolumetric relaxation. Okay, in the beginning of the isovolumetric relaxation. Completed. Okay, next, what else you should know is S3 heart sound. Okay, don't go with the ejection click opening snap, not needed. S3 and S4. See, this S3 heart sound, it is heard during, and S4 heart sound is heard during which phases? Which phases of the cardiac cycle? Again, just try to recollect, guys. How many phases are there in the systole? 3 phases. Isovolumetric contraction, rapid ejection phase, REP, and slow ejection phase, SEP. Okay, here I am showing isovolumetric contraction, rapid ejection phase, and slow ejection phase. Okay, done. Now, look here in the diastolic phases. There are 5 phases in the diastole. But in which phase S3 is heard? Look and tell me. See here, this phase, there is a phase called as rapid ventricular filling. Okay, ventricles are getting filled, rapid ventricular filling. Okay, so during rapid ventricular filling, blood is filling into the ventricles, right? Blood from the atria, it is coming down into the ventricles. That will cause a sound. Okay, so that is called as S3 heart sound. So look here, S3 heart sound. So S3 heart sound is during rapid ventricular filling, MCQ. And also remember, I am asking you, just try to answer it. Rapid ventricular filling, ventricles are getting filled. By actively or passively? During rapid ventricular filling, the ventricles are getting filled with the blood, and that filling of the ventricles can cause the sound, that is the S3 heart sound. Now question is, this rapid ventricular filling, is it happening actively or passively? Say this rapid ventricular filling, it is a passive phase. It's a passive filling. 70% of the ventricles, MCQ, 70% of the ventricles are filled passively. Means no need of atrial contraction. Most of the students will think atrial contraction will cause filling of the ventricles. Yes, that's true. But 70% filling of the ventricles happen passively. So simply blood will directly fall into the ventricles without even atrial contraction. So rapid ventricular filling phase is a passive phase, which is 70% filling of the ventricles. Then if 70% ventricles are filled during rapid ventricular filling, then 30%, the other 30%. See, atrial systole, guys, see, the atrial systole, it accounts for 30% filling of ventricles. So 30% filling of the ventricles is due to atrial systole. So atria will contract, fills 30% of the ventricles. So atrial systole is active phase. Okay, atrial systole is active. Now comes the question. See, now even when the atria is contracting, when the atria contracts, even it causes a sound. Okay, the atrial contraction will also cause a sound, and that sound is S4 heart sound. Okay, see, this is the beauty. Now S1 is heard during isovolumetric contraction, in the beginning of the isovolumetric contraction. S2 is heard during protodiastole. S3 is heard during rapid ventricular filling, that's a passive filling of the ventricles, 70% filling of the ventricles. And S4, okay, S4 is heard during atrial systole, where 30% ventricles are getting filled. Okay, done. Okay, these are the important points which I want you to know. S1, S2, S3, S4. And my question to you is, in healthy individuals like you and me, now usually the S3 and S4 heart sounds, they are not heard. Okay, S3 and S4 heart sounds, they are usually not they are not heard. They are very low pitch heart sounds. They are usually not heard. They are heard in pathological conditions. But one MCQ is S3 heart sound is physiological. It's a physiological in children. In children you can hear this, okay, but in adults no. So S3 heart sound is physiological in children. Done? Completed? Now after this, what else I want you to know? Guys, we have discussed about the heart sounds, 4 important heart sounds, S1, S2, S3, S4, and their phases when these heart sounds are heard. Now I have also discussed that S3 and S4 heart sounds. See, in the entire medicines, there are these heart sounds which are low pitch heart sounds, which means you cannot hear them with the normal side of the stethoscope in healthy individuals. Only you can hear them in pathological conditions. That too with the not with the diaphragm side, but with the bell side. There is a small side of the stethoscope, right? It's called the bell side. So these heart sounds like S3, which is heard during again rapid ventricular filling, S4 that is heard during atrial contraction. And there is a sound called as a tumor plop sound. And this tumor plop sound, they will ask you the question, sir, this tumor plop sound is seen in which condition? See, whenever you are having a tumor, look here, there is a tumor which is called as a atrial myxoma, means tumor in the left atria. Okay, there is a tumor in the left atria which is arising from the interatrial septum. Okay, there is a interatrial septum, right? From there, this tumor is arising, and this tumor, it's a pedunculated tumor. It's a dangling. Okay, it's a pedunculated tumor. It will dance and it will cause heart sound. Okay, so this tumor plop sound is heard in a condition called as atrial myxoma. In the medicine, these are the only low pitch heart sounds. So S3, S4, and tumor plop sound. These are the low pitch heart sounds. Okay, so these are the points which I want you to know. Next, what else you should know for your exams? Guys, without knowing these things, you cannot understand the left ventricular pressure volume loops. What are they? See, end-diastolic volume and systolic volume. Sir, what is this end-diastolic volume and what is this end-systolic volume? Simple, man. Look here. Let me draw a heart for you. A 4-chambered heart. Left atria. Sorry. This is not left atria, this is right atria. Okay, right atria, right ventricle, left atria, and left ventricle. Okay, now say, now normally, heart is there, right? Left ventricle is there. I'm talking about the left ventricle. Now heart is filling with the blood. Yes, right. Heart is filling with the blood. Now, how much blood is going to fill into the left ventricle before contraction? See, ventricle is absolutely relaxed. Ventricle is now relaxed like this. Now, ventricle is getting filled with the blood. Okay. Now, how much blood is going to get filled in this left ventricle? How much blood? So that is called as end diastolic volume. End diastolic volume means at the end of the diastole, means at the end of the relaxation phase. How much blood is going to be filled in the left ventricle? Somewhere around 120 to 150 ml. So your heart is going to be filled with almost 120 to 150 ml of blood. Okay. So with every contraction, okay, now 120 ml blood is there or 150 ml blood is there. Okay. Now with every contraction, okay, how much blood is going to come out? Out of 120, there is 120 for example, round figure, like 120 or 140, 150, the range from 120 to 150. If there is 120 ml blood, with every contraction, how much will come out? That is called as stroke volume. Okay, so blood coming out, blood ejecting with a beat. Okay, blood ejecting with one heartbeat. This is called as the stroke volume. And how much is the stroke volume? Do you know? The stroke volume will be somewhere around 70 ml to 90 ml. Okay, so with every heartbeat out of this 120, once if the heart contracts out of 120, do you think all this 120 will come out? No, all this 120 won't come out. 120 is filled, but with every heartbeat, 70 will come out or 90 will come out. 70 to 90 depends on the performance of the heart. Okay, and this is the stroke volume. Okay, stroke volume also completed. Now, after this, what you should know? Out of this 150, okay, 150 is the end diastolic volume. Okay, end diastolic volume is 150 or 140. Now, out of this, for example, 150 is there. Now, out of this 150, maybe, now how much is coming out? 90 is coming out. Okay, 90 is coming out. Out of 150, 90 is coming out. So, how much is left over in the heart? Still in the heart, something is left over. Means all the time in the heart, something is left over. Means even after the contraction, see, even after the systole, some blood is still in the heart. How much is that? That is called as end systolic volume, ESV. The end systolic volume, what is the value? The end systolic volume is out of 150, if you minus 90, 60 ml. A round figure, like round figure, we will talk about 50 ml. Okay, 50 ml of the blood is all the time there in the heart. Means even after the contraction, 50 ml is there in the heart. Okay, how much came out? 70 to 90 came out. But how much filled? How much is filled in the ventricles? 120 to 150, 120 to 150. Okay, so different books mention different things. So some books mention 120 to 140, some books mention 120 to 150. So completed. End diastolic volume is completed, 120 to 150. End systolic volume completed. End systolic volume is somewhere around 50 ml. And what is the stroke volume? 70 to 90 ml. Completed. Done. Now, after this, what else you should know for your exams? It's the murmurs. See, the importance of this end systolic volume and diastolic volume, that will be like, that you will understand better in the topic called as the left ventricular pressure volume loops. This is called as the LV pressure volume loops. Okay, this topic. Here you will understand that. But for now, first let's concentrate on the murmur part. Okay, sir, what are these murmurs? See, these murmurs are the abnormal sounds, right? Definitely. Now, how to understand this? Step by step. Look here in this time graph. Okay. See, systole is a phase which is present between which heart sounds? Look and tell me. So, systole it is present between S1 and S2. So, between S1 and S2, what do you have? Systole is there. And again from S2 and S1. Between S2 and S1, which phase is there? Diastole is there. So, systole is present between S1 and S2. And between S2 and S1, which phase is there? Diastole. So, in the same way, look here. So, this is the exact image based question. Exact image based question which was given in NEET PG 2023 exam. Image based question. I will tell you what is that also. Okay. See here, look here, concentrate S1 and S2. Between S1 and S2, which phase is there? Systole. So yes, this is the phase of systole. And between S2 and S1, which phase is there? Diastole. Here is the diastole. Okay. So now look here. In this phase, systole, there is a murmur present. Okay, there is this murmur present. So what is this murmur called as? This murmur is present throughout the systole. Again, say this murmur is coming throughout the systole with the same intensity. The intensity of the murmur is also same. So this is called as pansystolic murmur or holosystolic murmur, MCQ. So holosystolic murmur or pansystolic murmur. Okay. Now it is heard in which conditions? Important. It is heard in mitral or tricuspid regurgitation. Mitral regurgitation or tricuspid regurgitation. Now you can ask me, sir, what is this mitral regurgitation, tricuspid regurgitation? In a simple way, okay, under less than 30 seconds we can explain. See, what is this wall? This is the mitral wall. What is this wall? This is the tricuspid wall. Okay. See, when the ventricles are contracting, the blood was supposed to go into aorta and the blood was supposed to go into the pulmonary trunk. But what if this tricuspid valve is not closing properly? What if this mitral valve is not closing properly? What happens? So during systole, see, during ventricular contraction, blood is going back into the atria. So will it cause like an unnecessary sound or not? Yes, it do causes unnecessary sound. Okay, so that's why there is a murmur during systole or throughout the systole. What are the causes? The causes are tricuspid regurgitation or mitral regurgitation. So during mitral or tricuspid insufficiency means regurgitation only. Okay. So during mitral regurgitation or tricuspid regurgitation, there is holosystolic murmur or pansystolic murmur. Murmur is there throughout the systole. And any other condition, VSD, okay, ventricular septal defect. Okay, ventricular septal defect also called as a VSD. Sir. So what is this ventricular septal defect? Again, under less than 25 seconds, let's see this. Now, what is this septum called as, which I am showing you? So, this septum is called as the interventricular septum, right? Now, look here what is happening. Okay. Now, look here what is happening. There is a defect, interventricular septal defect. Okay, there is a hole. Okay. Now, what happens? All the time we know left side have higher pressures. See, left ventricle have higher pressures than the right ventricle. This is the right ventricle, this is the left ventricle. Now, left ventricle have a higher pressure. So, what happens when the left ventricle is contracting? Okay, when the left ventricle is contracting, during systole, high pressure is there. So what happens? The blood is going to unnecessarily, it's getting shunted towards the right side, into the right ventricle. So does it cause any murmur or not? Yes, it do causes the sound, it causes the murmur. But when murmur? During systole. So again, yes, this ventricular septal defect, VSD, even during ventricular septal defect, during systole, there is abnormal sound. The blood is getting shunted from left ventricle to the right ventricle. Okay. So, please tell me, holosystolic murmur or the pansystolic murmur? This is heard during which conditions? Mitral regurgitation, tricuspid regurgitation, ventricular septal defect. That's it. That's it. Okay. Next, the second type of murmur. Look, the second one. This is the first murmur completed. Now, look here, guys. This is the second murmur. Now, when this murmur is heard, during systole or diastole? First, tell me. Sir, even the second murmur, it is heard during systolic phase only. Okay, see, between S1 and S2. This is the phase of systole, right? The blue color one, which is the systole. Now, but important point is, the murmur intensity increases and decreases. Okay, murmur intensity is increasing, decreasing, increasing, decreasing. So, it's like a diamond shape, right? Okay, or rhombus shape. So, increase in intensity, decrease in intensity. Like, something like that. Okay, increases and decreases. So this murmur is called as a crescendo decrescendo murmur. So MCQ, crescendo decrescendo murmur. Yes, it's a systolic murmur. Or the diamond shaped murmur, rhombus shaped murmur. It is heard during which condition? Now it is heard in conditions like pulmonary stenosis or aortic stenosis. Remember simply aortic stenosis, subar or subaortic stenosis. They are one and the same. There is a difference. I will explain. Now, how to understand this? Okay, let me show you here. Okay. Guys, here I am showing you the crescendo decrescendo murmur right here. Crescendo decrescendo murmur. Okay, so now by this time you already know crescendo decrescendo murmur, rhombus shaped murmur, or the diamond shaped murmur seen in pulmonary stenosis or aortic stenosis. Why this murmur, sir? Now, if you look here, this is the heart in a simple way. Now, what are these outflows? These outflows from the left ventricle. What is this outflow called? This is the aorta. Right? And what is this one? This is the pulmonic trunk. This is the pulmonary trunk. Now tell me, what is this valve which is present over here? This is the aortic valve. What is this valve which is present over here? This is the pulmonic, that's the aortic valve, this is the pulmonic valve. These are the semilunar valves. Now what if they are totally stenosed? Stenosed means Now they are totally calcified, maybe. Okay, because of some senile reasons, there is senile calcific degeneration of these walls with age. Okay, with age, they are calcified. Now, whenever they are calcified, what happens? Now, left ventricle have to generate more pressure. Okay, now afterload is increased. Okay, because of the aortic stenosis, afterload is increased. Now it's totally narrowed. Now the ventricle have to generate more pressure to open these valves. They are calcified valves. So now there is a very little outflow. The outflow tract is getting calcified. Whenever the outflow tract is calcified, see, now left ventricle is generating more pressure. Even the right ventricle, they will generate more pressure. But see, what about the outflow? It's very much narrowed down. Let me show you here. See, now it is very much narrowed down. It's like a tunnel. So when the blood is going through this tunnel, will it make sound or not? Yes, it makes sound. So initially more blood will be there in the left ventricle. Okay, initially in the starting, more blood will be there in the left ventricle. When this more blood, when it start to go out into the aorta with higher pressure, what happens? The murmur sound also increases. But with the time, what happens? Blood is going out. Okay, the amount of blood in the left ventricle decreases. The pressure generated by the left ventricle also decreases. So less sound. So intensity of sound increases, later decreases. Increases, decreases. Initially more blood, so more sound. Simple. Later less blood, less sound. So both same, right side also the same thing. Okay, so both in pulmonic stenosis as well as aortic stenosis or subaortic stenosis, all the same things. There is crescendo, decrescendo murmur. The outflow tract is calcified. Now it's like a narrow tunnel. When the blood is passing through this narrow tunnel with high velocity, it causes some abnormal sound that is called as the crescendo, decrescendo murmur. Simple. That's the MCQ. Okay. So second murmur also successfully completed. Okay. Next, what we should know. So for your exams, especially FMG exams, the next murmur which I want you to know is, see, there is this murmur which is present in the systole as well as this murmur is continuing through the diastole. There is again murmur coming in the systole as well as the diastole. So systolic murmur as well as the diastolic murmur. What is this murmur called as? See, this murmur is called as the continuous murmur or machinery like murmur. Okay, so continuous or machinery like murmur. This is the third murmur which I want you to know. Okay, no need to remember these murmurs. So there is a continuous murmur, also called as a machinery murmur, seen in which condition? It is seen in a condition called as patent ductus arteriosus, PDA. Okay, so in a condition called as patent ductus arteriosus, there is continuous machinery murmur. Now, some students will have a doubt, sir, why this continuous machinery murmur? Okay, for them, let me show and let me give an explanation within just under 30 seconds. So, this is the heart. Okay, let me draw the heart in a different view so that you can better understand. See, this is the heart with right atria, right ventricle, left atria and the left ventricle. Okay, can you tell me what is this outflow? I am drawing the outflow now like this. What is the outflow from the left ventricle? What is that blood vessel that comes out of the left ventricle? Simple, aorta, sir. And what is that blood vessel which comes out of the right ventricle? Pulmonary trunk. Okay, so pulmonary trunk and the aorta. This is the, okay, let me write the terms also. This is the pulmonary trunk, this is the pulmonary trunk. Okay, now why I am showing them in red color and blue color, you know, they contains oxygenated, one contains oxygenated blood, aorta contains oxygenated blood and the pulmonary trunk contains the deoxygenated blood. Okay, see, if there is this abnormal connection, actually this is a connection which is physiological during like embryogenesis, during intrauterine period, this is okay. But if you have to if you have this connection even after the birth, see, there is an abnormal connection between these two blood vessels. So this abnormal connection, this is called as patent. Okay, before birth it is called as ductus arteriosus, that is okay. Before birth that connection is okay. But now this is called as PDA, patent ductus arteriosus. So now whenever there is this patent ductus arteriosus, do you know what happens? So this patent ductus arteriosus, it is causing left to right shunt. Okay, remember all the time during systole, diastole, 24/7, the pressure in the aorta is always greater than the pulmonary trunk. So what happened to the blood? Now the blood is going to shunt into the pulmonary trunk. Okay, 24 by 7, 24 by 7. It is not like during systole, during diastole, no, continuously throughout the day. The blood, it is some amount of blood, not the total blood, some amount of blood is getting shunted from the aorta into the pulmonary trunk. So do you think it will cause some abnormal sound or not? What do you guess? Yes, this unnecessary shunting will cause abnormal sound. So this is called as machinery murmur. Okay, machinery murmur, also called as a continuous murmur. Why we are calling it as continuous murmur? Why? Because it happens continuously. So continuous murmur or machinery murmur, it is seen in patent ductus arteriosus. Crescendo, decrescendo murmur seen in pulmonic stenosis or aortic stenosis or subaortic stenosis. Okay, the next murmur, holosystolic murmur or pansystolic murmur seen in mitral regurgitation, tricuspid regurgitation or ventricular septal defects. If you know this, enough. If you know these murmurs, enough. Now, after this, what else they will ask you in your exam? So if I am the examiner, I will definitely give you this question only. Why? Because this is a question which was tested in many FMG exams and many PG exams. Many FMG and many PG exams, this one graph they will ask you. See, here I am not going in detail. First of all, I am not going in detail, but I will tell you what you should know for your exam. Okay, even the recent NEET PG exam, this question was there. Okay, recent NEET PG exam also this question was asked. Okay, see, one thing again I am telling you, if you know these concepts enough, okay, 100%, if you know these concepts, if you watch this rapid revision part 1 as well as part 2 and go to the exams, you will answer all the physiology related questions with flying colors, just like that. Okay, now first, when students look at this graph, they will feel depressed. Oh my god, sir, graphs we can't understand. Simple, man, simple. See, on this x-axis, what I am showing you, I am talking about the volume, some volume. And do you know these volumes? What are these volumes? Sir, the volumes which I am talking here are the end systolic volume, ESV, end systolic volume. What is that end systolic volume, sir? Even after systole, how much blood will be there in the ventricles? Even after systole, 50 ml blood will be there. So that's why, see, I am starting the point here. Look here, the end systolic volume, I am starting from this 50 ml. Okay, 50 ml blood is there. Now ventricle is like this. How much blood is there? 50 ml is there. Now ventricle is like this. It's contraction completed. Now, even now 50 ml blood is there. Now what will happen? Ventricle is now getting relaxed, completely relaxed, and now it is getting filled with the blood or not? Yes, 50 ml is not sufficient. It have to fill 140. It have to fill 140. Okay, so now look here, the ventricle is getting filled with the blood. So that's why, look, the graph is moving, the pink color line. So what is the importance of this pink color line? See, yeah. So here what I am showing you is the ventricle is getting filled. Ventricle is getting filled. And how much filling? How much it will fill? So at the end of the diastole, how much volume is going to be there? See, 120. So end diastolic volume is going to be 120. Okay. So this top, in the bottommost, in this graph, the bottommost curve, what it is representing? Ventricular filling. Ventricle is getting filled. Okay, ventricle is getting filled. Okay. Now questions what they will ask you is, see, what is this starting point? See, at this starting point, what happens? They will give you, I am giving the mark A. Okay. So what is happening now? See, ventricle is like this. Okay, ventricle is like this. Ventricle have to fill, no. Think logically, man. Ventricle have to fill. Okay, let me show you the image so that you will have a better clarity. Okay, I'm talking about, say, for example, mainly I'm talking about the left side. Left side. What is this left atria? And what is this? This is the left ventricle. Now, how much blood is there? 50 ml is going to be there. That is the end systolic volume. Now, if the left ventricle, if it have to fill, now tell me which valve should open. So there is a valve called as a mitral valve. It is closed actually. During systole it is closed. Now, if you want the ventricles to be filled, now what happened to the mitral valve? This valve have to open. It have to open. Then only the blood will fall into the left ventricle. So that's why, see, in the beginning at the A point, what is happening? The mitral valve is opening. Mitral valve opened, so blood is falling into the left ventricle. So left ventricular volume increases from 50 to 120. So that's why, look here, the volume is increasing. Now, how much increased? 120. So left ventricle is having how much volume now? 120 volume. Now tell me, after filling, what should happen? After filling, what should happen? The ventricle have to contract. Ventricle have to contract. But before contracting, see, now ventricle if it contracts, the blood have to, look here and tell me, sir, now because of the filling, how much blood is there inside the ventricle? Now filling completed. Okay, now filling completed. Now let me write here, there is 140 or 150 ml of blood is there. 140 to 150 ml of blood is there. That is the end-diastolic volume. Okay, end-diastolic volume. See, the range can be 120 to 140 or 150. Okay, I have already cleared this. 120 to 140 will be the range. The left ventricle will fill. Now, when the ventricle is filled, tell me the blood where it have to go? The blood have to go into the aorta, but not into the left atria. It should not go into the left atria. So what should happen? Sir, when the ventricles are filled properly, 140 ml, 120 ml, they are filled. So first what should happen? Now this valve, this mitral valve, it have to close. Okay, the mitral valve have to close. Okay, so that's why whenever you are having this 120 ml of blood, okay, whenever you are having 120 ml of blood or 140 ml of the blood, what is happening? See, at this phase, at this point, immediately what happened? Mitral valve is closed. So at A, mitral valve opens. At C point, they can give you any number like 1, 2, 3, 4 or A, B, C, D, doesn't matter. At A in this graph I am showing you mitral valve is opening, and at C mitral valve is closing. From A to C what is happening? See, from A to C, this area, the left ventricle is getting filled. Okay, again I am telling you guys, this graph is called as left ventricular pressure volume loop. We are talking only about the left ventricle, not about the right ventricle. We are only talking about the left ventricle. Okay, so done sir, completed. Now after this what is happening? After this, see, mitral valve is closed. No, mitral valve is closed. Once the mitral valve is closed, now what is happening? See, the left ventricle, it is contracting. When the left ventricle is contracting, pressure increases or not? Tell me. Inside the left ventricle, see, the left ventricle is contracting. When the left ventricle is contracting, the pressure inside the left ventricle increases. Okay, how much increase, sir? You know, right? The first pressure will increase to 80. So that's why, see, now do you know what is this blue color phase which we are showing here? See, this blue color line, what is happening? See, the pressure in the left ventricle is increasing up to 80. Now for the first time we are talking about this axis. What is this y-axis? On the y-axis I am talking about the pressures. I am talking about the pressures in the left ventricle. On the x-axis what I am talking about? On the x-axis I am talking about the volume of blood in the left ventricle. Volume of blood in the left ventricle. On the y-axis I am talking about the pressure in the left ventricle. Okay, see, now after filling 120 ml of blood, left ventricle is contracting. When the left ventricle is contracting, the pressure increases to 80. Okay, the pressure is increasing to 80. Do you know what is this phase called as? This phase is the systole, right? So this phase of the systole is called as isovolumetric contraction. Aha, now you understood. Previously we have discussed, see here, in the systole, in the beginning I asked you to remember, see, in the systole, what is the first phase? Isovolumetric contraction. Do you know what is happening during isovolumetric contraction? So during isovolumetric contraction, the pressure is increasing up to 80. Okay, the pressure is increasing up to 80 mmHg. Now we'll get it out. Sir, after isovolumetric contraction, what is the next phase? Rapid ejection phase. Rapid ejection phase, simple. But look here. Okay, this timeline diagram is very important, guys. Even if it takes some time, not an issue. Look here. Same. Isovolumetric contraction, you already know. It starts with S1 heart sound. Means mitral valve. See, mitral valve is closed. Mitral valve closed. Isovolumetric contraction. Pressure increases to 80 mmHg. Now, do you know what happens? Sir, when the pressure is 81 mmHg. Now look here. Look at in this left ventricular pressure volume loop. Now comes here. Now 80 pressure, okay. But when the pressure becomes 81 mmHg, do you know what happens? Immediately aortic valve is now opened. Okay, now aortic valve is opened. So in a simple way, look here. This is your heart. Okay. Now this is the mitral valve. This is the tricuspid valve. What is this one? This is the aorta. Okay. Now heart is like, this normally aortic valve is all the time closed. This aortic valve, it's closed. Aortic valve is closed. Now what it is doing? Heart is generating a pressure of 80. Okay. But when the heart pressure, when it becomes 81, when it crosses 80 and becomes 80.1, Okay, now what happens? Immediately this valve will open, this aortic valve, it will start to open. Aortic valve is open now. Okay, the aortic valve is open. So immediately what happens? Very rapidly blood is going to eject into the aorta. So that's why, please tell me what happens at this D point. At this D point, aortic valve is opened. Once aortic valve is open, what is the next phase? See, next we are going to have the rapid ejection phase. Now rapidly blood is getting ejected. But also know one point. This left ventricle, it is still contracting. At 80, this valve is open. But left ventricle, it is still contracting. And the pressure which it will generate is maximum of 120 mmHg. 120 mmHg. Okay. See, everything you will understand. Just listen what I am saying you. Okay. Now, what I am showing you here. So, the left ventricle maximum, how much it will generate a pressure? It will generate a pressure of 120 mmHg. So, what is this phase called as? This phase which I am showing you is called as a rapid ejection phase. Rapid ejection phase, where the pressure is moving from 80 to 120 mmHg. Okay, done, completed. Now, next, what is the next phase? The next phase after rapid ejection phase, you are having slow ejection. Why we are calling it as a slow ejection? Because see, now the pressure is falling from 120, the pressure is falling from 120 again back to 80 mmHg. The pressure is falling, so the ejection of blood into the aorta is also decreasing. Okay, the ejection of blood into the aorta is also decreasing. So that's why this is called as slow ejection phase. Blood is going out but slowly. Okay, so now please tell me here, this is x-axis and this is y-axis. Okay, on x-axis I am telling you, I am showing you two values. What are they? 50 ml and 120 ml. For example, 50 ml and 120 ml. What is this 50 ml and what is this 120 ml? You should tell me. See, here I am showing you what is this. This is the curve which I am showing you. Like this, there are certain points. Point number A, point number B, point number C. Not like this. Point number C, point number D, point number E. Now, see, here the pressure is, let me show you the graph like this. Okay, now this is the pressure of 80, this is the pressure of maximum 120. Okay, now what is this graph? First of all, this graph is left ventricular pressure volume loop. Left ventricular pressure volume loop. Now, what is this point number A? Which event is happening during point number A? Simple. Mitral valve opens. Mitral valve opens. Okay. And how much blood is there inside the ventricle at the starting point? And systolic volume, that is 50 ml. 50 ml. So, what is this point B called as? This B point or the C point? Doesn't matter. They will give you any number. This point is called as, sorry, this point is B point. What happens during here? Here, mitral valve closes. Mitral valve closes. And what? This is the C point. Okay. This is point number C. Oh. This is the point number C. Now, what is this phase? What is this phase? This is the isovolumetric contraction. IVC, isovolumetric contraction. The pressure is increasing. Okay. Up to 80. Now, which event happens during C point? During C point, aortic valve opens. Aortic valve opens. Okay. Now, from C to D, for example, if this is point number D, what is this C to D phase? This is called as a rapid ejection phase. Rapidly the blood is getting ejected. Rapid ejection phase. Now, from D to E, what is this D to E is called as? Now, this D to E, it is called as a slow ejection phase. SEP, slow ejection phase. And what happens when the pressure in the left ventricle, when the pressure in the left ventricle, when it is coming down below 80, what happens? So now again aortic valve closes. Okay, aortic valve closes. That's what I have shown you here also. Look here. See, when the pressure, when it comes below 80, immediately aortic valve again closes. Okay, aortic valve is now closing. So at F point, aortic valve closes. Okay, this area, aortic valve closes. Now, once aortic valve is closed, okay, heart is contracted. Now, what is happening? Blood also went out. Isovolumetric contraction, rapid ejection phase, slow ejection phase completed. Now heart is relaxing like this. When the heart is relaxing, what happened to the pressure inside the heart? Decreases. So now look here, the pressure is falling down, the pressure is coming down. From 80, the pressure is falling down. So what is this phase called as? This is called as isovolumetric relaxation. This is called as IVR. This orange color curve which I am showing you is called as the IVR. Okay. So my dear students, here I will show you certain points. You just tell me what they are. Okay, this is the left ventricular pressure volume loop, right? This is the left ventricular pressure volume loop. So these are the points. Okay, now you please tell me what are these points. This is the point number A, B, C, D, E. A, B, C, D, E. Now, what event happens at A? You think and tell me. So at A, what happens? Mitral valve opens. Okay, mitral valve opens. At B, what happens? At B, mitral valve closes. Okay, mitral valve closes. Now from A to B, what is happening? Left ventricle is getting filled. Left ventricle is getting filled. Okay, ventricular filling. So at A, it is end systolic volume of 50 ml. And at B, end diastolic volume. The ventricles are getting filled. How much? 120 ml, 120 to 150 ml. Okay. Next, what is this phase from B to C? The phase from B to C is called as isovolumetric contraction. What is the phase from C to D? The phase from C to D is called as rapid ejection phase. What is the phase from D to E? This is called as the slow ejection phase. Now, what is the event that happens at C? At C point, aortic valve opens. Aortic valve opens. What is the event that happens at the E? Aortic valve closes. What is the event from E to A? What is this event? This is called as isovolumetric relaxation. Ventricle is relaxing. The pressure is coming down. Okay, pressure is coming down. Okay, so 100% the question will come from this area only. They will ask you only these things. What is isovolumetric relaxation, isovolumetric contraction, rapid ejection phase, slow ejection phase, which valve opens, which valve closes. Okay, so these are the questions that they will ask you. Okay, and the one more thing for your exams which I want you to know is the difference between these 2 points is called as a stroke volume. Okay, the difference between these two is called as a stroke volume. Simple, no? See, what is this one? This point and this point. The difference between these 2 points is a stroke volume. How can you, how can we say this is a stroke volume? Simple. End diastolic volume is how much? 120 minus 50. Okay. So 120 minus 50 is how much? 70 ml. That's the stroke volume. How much is filled, sir? How much ventricle is filled? 120 is filled. After contraction, how much is left over? 50 is left over, which means how much came out? 70 came out. Okay, 70 came out. So this is the stroke volume. So difference between these 2 points, the difference between these 2 points is the stroke volume. More the difference, more stroke volume. Okay. Now, again, this was the question which was asked in the FMGE exam. Okay. See, now you know, these are the left ventricular pressure volume loops, right? Okay, these are the left ventricular pressure volume loops in different conditions. Okay, here I am showing you 4 different conditions. I am not going in detail, just by looking at that you can say. See, whatever which was given in this dark color, that is something normal. The left ventricular pressure volume loop. Okay, normal pressure volume loop, sir. That's a normal thing. But whenever you see in a condition called as aortic stenosis, aortic valve is closed, is stenosed. Then do you know what happened to this left ventricular pressure volume loops? It is going to be like a tall tree. Okay. Why it is a tall tree, sir? We can explain, but we don't have enough time. Whenever you see such a tall left ventricular pressure volume loop, blindly answer it is AS, aortic stenosis. Aortic stenosis. Simple. If you think logically, you can answer this. Why? Why? Because normally, how much maximum pressure a left ventricle will generate? A left ventricle will generate a maximum of 120 mm Hg pressure, sir. But now aortic stenosis, aortic valve is stenosed. So to pump the blood into the aorta, now left ventricle have to generate more pressure. That's why see it's generating more pressure, 200. Left ventricle is generating more pressure to send the blood into aorta. Okay, so simply tell me, whenever you see such a tall tented left ventricular pressure volume loop, what you should think? Aortic stenosis. Completed. Okay, now in this condition, what is happening? Left ventricular pressure volume loop is now more shifting towards, for example, here. Now let me show you. This is the left side, this is the right side. If I show you left and right sides. Okay. Now the graph, the left ventricular pressure volume loop, it is more shifting towards the right side, right? It is moving towards the one side, right side. Then the condition is aortic regurgitation. I'm not going in detail, just like a by hearting things, just like a mnemonic kind of thing. You can remember, if left ventricular pressure volume loop is shifting towards the right side, regurgitation. Which regurgitation? Aortic regurgitation. Right side regurgitation, aortic regurgitation. Okay. So next, look here. Whenever you see this left ventricular pressure volume loop, if it is getting smaller and smaller, chota, like it's getting smaller and smaller like this, then this condition is mitral stenosis. This was the question asked in the NEET PG exam, FMGE exam. These are the questions asked. Whenever you see such a small left ventricular pressure volume loop, it is going to be seen in which condition? Mitral stenosis. Okay, mitral stenosis. Done, completed. And whenever you see, look here, the left ventricular pressure volume loop, it is shifting towards the right side as well as left side. Like, it's like an obese person on both the sides. It is extending like this. Then what is this? What might be the condition? They will give you simply, they will give you this image-based question, and they will ask you what is wrong with the patient? What is wrong with the patient? That's what they will ask you maximum. Okay. So whenever you see this left ventricular pressure volume loop is extending on both the sides, the answer will be this is mitral regurgitation. Only on one side it is aortic regurgitation. Only on right side it is aortic regurgitation. But on both the sides it is mitral regurgitation. Okay. So even without looking anything, just answer this. Look here. Here I am showing on x-axis. This is y-axis. Now I am showing you. See, the left ventricular pressure volume loop is something like this. And the second one, the left ventricular pressure volume loop, it became small like this. Okay, x and y. Now the left ventricular pressure volume loop, when compared to normal, it is more deviating towards the right side. And x and y, it is the left ventricular pressure volume loop, it is extending something like this on both the sides. Can you tell me the abnormalities in which conditions? This first one. Can you tell me what is this A? So this is aortic stenosis. In aortic stenosis, you are having the tall tented left ventricular pressure volume loop. Small left ventricular pressure volume loop is going to be seen in mitral stenosis, MS. Okay, and this one, the third one, ABC, this third one, it is more towards the right, it's more moving towards the right. Then it is aortic regurgitation. On both the sides, it is mitral regurgitation. That's it. Okay, these are the questions that will come in your exams. Okay, so mitral regurgitation, tricuspid regurgitation. See, the second lecture, this is the first part. The second part will be most probably a day after tomorrow. Okay, so the second part is going to be coming most probably in day after tomorrow. Okay, so done, sir. Left ventricular pressure volume loops are also completed. Now they will ask you, in which left ventricular pressure volume loop the stroke volume is increased so much. Stroke volume is increased so much. It looks like the stroke volume is increased so much. Can you tell me? See, look here, I have said you the difference between these 2 points. Okay, the difference between these 2 points is the stroke volume. Okay, so if you look at this mitral regurgitation, the condition, the mitral regurgitation, stroke volume is too much increased. It looks like, actually it's not, but it looks like the stroke volume is too much increased. The difference between these two. Okay, that's the MCQ. Okay, so the stroke volume is very much increased in the mitral regurgitation. So done. Now after this, what we should know? The next important topic is jugular venous pressures, JVPs, jugular venous pressures. So in this jugular venous pressures, how many waves are there? Simple. A wave, C wave, V wave, X wave and Y wave. Okay. A, C, X, V, Y. AC, X, V, Y. These are the jugular venous pressure waves. Most of the students, they don't understand the concept of the jugular venous pressures easily. It's very simple. It's very simple. See, there is a jugular vein which is bringing the blood from the head and neck, deoxygenated blood from the head and neck. Now, try to understand like this. Here I am showing you only the right atria. Only see, I am showing you the right atria. Okay, and I am showing you the jugular vein, internal jugular vein. Anatomically, this is not correct. Like, the deoxygenated blood is coming into the right atria via the superior vena cava and inferior vena cava. Everyone knows that. But what I am saying you is, sir, see, internal jugular vein, which is present in your neck, it is bringing the deoxygenated blood into the right atria. Right? See, if there is any pressure change, try to understand that right atria and internal jugular vein, they are almost connected each other. Okay, they are almost connected. If there is any pressure change in right atria, that will also cause pressure change in the internal jugular vein. If pressure increases in right atria, internal jugular vein pressure also increases. If pressure decreases in right atria, internal jugular vein pressure also decreases. So, the atrial events, especially right atrial, not left atrial, right atrial events will change the pressure in the internal jugular vein. Okay. So, now let's see what is normal and what is abnormal. And again, question was asked in the recent NEET PG exam. See how many questions were being asked just from one cardiovascular system. You might think like, why I'm taking so much time about the just for the cardiovascular system. You will think like, sir, if you take so much time for the cardiovascular system, then what about the other? See, I know where the questions will come from. What are these important topics? We can complete the entire rapid revision session in 2 hours also, but that won't be really helpful for you. Target is to complete all the important topics so that you will answer all the MCQs. Okay. Now, sir, look here. What are these ACX and ACXVY waves? What are these waves? Normally, I am asking you, your atria will contract or not? Right atria. It will contract, right? When the right atria is contracting, what happened to the pressure in the right atria? Right atria is contracting. When the right atria is contracting, the pressure in the right atria increases. Also, the pressure in the internal jugular vein increases. So, if you are measuring the pressures, in the internal jugular veins, say, now the pressure in the internal jugular vein is increasing like this. So, this is called as the A wave, means positive wave. The pressure is increasing in the internal jugular vein. Why? The atria is contracting, the right atria is contracting. So, automatically the pressure in the internal jugular vein is also increasing. Okay. So, that's why this A wave, it is seen during atrial contraction. When the atria is contracting, the pressure in the internal jugular vein is also increasing. Try to understand it like this. Okay. For like I'm just trying to make it as simple as possible. Okay. So, A wave is seen during atrial contraction. Okay, after atrial contraction, what happens? Atria is getting relaxed, simple relaxed. So that's why see the atria now is relaxing. So that's why the pressure also coming down. But something now happens. Look here, I'm showing you. This is the right atria, this is the right ventricle. And what is this blood vessel which I am showing you on the top? The blood vessel which I am showing you on the top, this is the internal jugular vein. Okay, internal jugular vein. Okay. See, now atrial contraction completed. Now atria is relaxing like this. Okay. Now suddenly what happens? Right ventricle will contract. After right atrial contraction, what will happen? Now ventricle will contract. When the right ventricle contracts, do you know what happens? Sir, this wall, what is this wall which is present over here? So this is the tricuspid wall. This tricuspid wall actually it will bulge. Okay, the tricuspid wall actually it will bulge into the right atria. When the ventricle is contracting, the tricuspid wall it will bulge into the right atria. So what happened to again now the right atrial pressure again increases. Why? Because this valve is coming, no, it's ballooning into the right atria, no. So right atrial volume decreases, pressure increases. So that's why there is a little pressure increased. So also in internal jugular veins, pressure increases. So that causes the C wave. See this C wave. Why? What is the importance of this C wave? C for closure, the tricuspid valve is closed, this tricuspid valve, it enters, okay, it balloons little into the right atria, so right atrial pressure increases, okay, little increase. So A wave is because of the atrial contraction and C wave is because of the closure of the tricuspid valve, and in like ballooning of this tricuspid valve into the right atria, it causes elevation of the pressure in the right atria and elevation of the pressure in the internal jugular veins. That's it. Okay, done. Sir, after this what happens? So A wave, C wave are completed. Both this A wave and C wave, both these are the positive waves. Why? Because pressure is increased. These are the positive waves. Now, sir, atria contracted. Now, what happens after atrial contraction? A wave completed. Now, atria is completely relaxing. Completely relaxing. See, now, that's why, see, the pressure is coming down. Okay, so this X. So, X, this X wave, which is coming down. So, what is happening during this phase? Sir, atria is completely relaxing. But you should also know, when the time atria is relaxing, what happened to the ventricles? Ventricle is contracting. Atria is in relaxation mode, but ventricle is in contraction mode. So during this X phase, which cardiac events are happening? Okay, which cardiac events are happening? Atria is relaxing, but ventricle is contracting. Okay, so that's why X is systole of the ventricle. The systole of the ventricle. Atria is relaxing, so pressure is going down. But at the same time, ventricle is contracting. Okay, answer. X wave also completed. X for, remember, X for relaxation. X for atrial relaxation. Atria is completely relaxing, but ventricle is contracting. Okay, done. Next, what happens? Next wave is called as a V wave. Okay, the next wave which I want you to know is this V wave. ACX VY, right? V wave. V for, remember, sir, atria contracted. Atria is now relaxing. So pressure also coming down. But what is this V? Once atria is relaxed, now it will fill with the blood, right? Atria have to fill with the blood. Now when the atria is filling with the blood, pressure again increases in the atria. Why? Because venous blood is coming, right? So that's why when the atria is filling, when the atria, right atria, whenever it is filling with the venous blood, okay, when the right atria, whenever it's filling with the venous blood, now look here, what is happening? Now the pressure is increasing. The pressure is increasing. So that's why this V wave, V for venous return or venous filling. Venous filling of atria. Okay, maximum atrial filling. The atria are filling with the blood, not ventricles. Atria are filling with the blood. So that's why the pressure is increasing. Now atria are having full blood, sir. Atria are filled with the blood. Now what happens? The blood from atria will go up into the ventricles. So atrial filling completed. What valves open? The tricuspid valve. The tricuspid valve, it will open. The blood will fall down. The blood will fall down into the ventricles. So pressure in the atria will decrease. So V wave completed. V wave is because of the venous filling. Now after that, if you see here, what is happening? What is the next wave? The Y waves. Y wave. So Y wave is because of Y for empty. EMPT Y. Okay. So emptying. EMPT Y is there, right? Y. So Y wave is because of the atrial emptying. Atria are leaving the blood into the ventricles. Okay, atria are leaving the blood into the ventricles. So atrial pressure decreases. Internal jugular vein pressure also decreases. Okay. So done, sir. So these are the MCQs which I want you to know. Now please tell me here. Now, how many waves are there? There is A wave, C wave, X wave, V wave and Y wave. Okay, so A, C, X, V and Y. A, C, X, V and Y. Now please tell me guys, one. A wave is because of, can you tell me? A wave is because of, sir, A wave is because of atrial contraction. C wave. C wave is because, they can ask you, what is the event that is happening during C wave? C wave is because of closure of tricuspid valve. The tricuspid valve is closed. The tricuspid valve is closed and it's ballooning into the right atria. Right atrial pressure increases, internal jugular venous pressure also increases. Now this X wave, what is this X wave? Atria is relaxing, completely atria is relaxing. The pressure in the atria comes down, the pressure in the internal jugular veins also comes down. Okay, so but important point is, sir, during X, what other cardiac event is happening? Ventricular systole. When the atria is when the When the atria is relaxing, ventricle starts to contract. So here, now there is ventricular systole is happening. Okay. Now, what is this V wave? What is this V wave? So this V wave, remember, V wave is because of the venous filling. When atria is getting filled with the blood, so atrial pressure increases, internal jugular venous pressure increases. So V for venous. Okay, V for venous filling. My God, just give me 1 minute. V for venous filling. Okay. V for venous filling. And what is happening during this Y? Y for empty, atrial emptying. Okay. Atrial empty. So that's it. Completed. So atrial emptying also completed. So ACXVY waves are completed. Now I'm asking you, just look at this and tell me which are positive waves and which are negative waves. Which are positive waves and which are negative waves? See, the two negative waves are X and Y. XY, remember, X and Y are negative waves. Why? Because the pressure is going down. The pressure is going down. So X and Y waves, they are negative waves. Okay. So right, X wave. That is atrial relaxation. Atrial relaxation is happening and ventricular systole is happening, and Y, atrial emptying is happening. So both these are negative waves. Okay. Now, what was the question which was asked in the FMGE exam as well as the NEET PG exam? Which question was asked? FMGE exam. This question was asked. See, this was the question. First, let me come with the basics. Okay. Alright, please tell me, students, please tell me. A wave is because of what? Atrial contraction. Atrial contraction causes A wave in the jugular venous pressures. Atria is contracting, right atria is contracting, pressure in the internal jugular vein also increases. Okay, that's the A wave. Now, look here. Large A waves are seen in which conditions? I'm not going in detail. They will ask you in the jugular venous pressures, large A waves are seen in tricuspid stenosis and pulmonic stenosis. In the conditions called as the tricuspid stenosis and pulmonic stenosis, there are large A waves. Okay, why? If you ask me, look here. This is the heart. Okay, I'm just giving you one example. This is the right atria. What is this wall? Can you tell me? This is the tricuspid wall, right? This is the tricuspid wall. Now, this tricuspid wall, it is totally stenosed. It's totally stenosed, sir. It is totally calcified and it is stenosed. Okay. Now, if it is stenosed, now how much pressure the right atria should generate? Tell me. It have to generate more pressure. The blood is not going in the forward direction. The blood is not going in the forward direction. The right atria have to generate more pressure. So, when right atrial pressure increases, what happens to the internal jugular venous pressures? Internal jugular venous pressures also increases. Okay. So, during right atrial contraction, it generates more pressure. So, A wave also will be large. So, large A wave. So, that's right. Is seen in tricuspid stenosis. Okay. So, large A waves are seen in tricuspid stenosis and pulmonic stenosis. That's it. Next, what else you should know? See, absent A waves. This was the question which was tested in the exam. I'm concentrating on those questions which were asked in the previous exams now. Okay. Absent A waves are seen in C. Now, only like look here. Which waves are seen? No need to remember the graph. The graphs are not important. Only terms are important. There is no A wave. A wave is not seen. Now, think logically and tell me. Sir, A wave is because of right atrial contraction. If right atria or if atria is not contracting, then A waves cannot be there in the jugular venous pressures. So, A wave is absent in which condition? Absent A waves are seen in conditions like atrial fibrillation. Okay. So, in the conditions like atrial fibrillation, see, atria are not contracting. Atria are just quivering like this. Atria are not contracting, sir. They are just like shivering. Okay. So, in the conditions like atrial fibrillation, there is no A wave. A waves are absent. So, now tell me, large A waves are seen in tricuspid stenosis, pulmonic stenosis. No A waves or absent A waves are seen in atrial fibrillation, where atria is not contracting. You can write here atrial fibrillation or atrial Sorry, it was given here also. Seen in conditions where there is atrial asystole, atria are not contracting, no A waves. Simple. Okay. Next, what else you should know? Next important MCQ is canon A waves. Okay. Sir, what are these canon A waves? Canon A waves. Okay. In which conditions you will see canon A waves? Normally, guys, remember, atria will contract followed by ventricular contraction. First atria will contract, later ventricles will contract. Both atria and ventricles, they do not contract at the same time. Okay, they do not contract at the same time. First atria will contract, fills the ventricles, then ventricle will contract. Atrial contraction, ventricular contraction. Atrial contraction, ventricular contraction. But sometimes, because of some pathologies, both atria and ventricles, they will contract at the same time. So this is called as atrioventricular dissociation. So in the conditions called as AV dissociation or atrioventricular dissociation, both atria and ventricles will contract at the same time. Now, do you know what happens? The entire heart is like contracting like crazy. At the same time, the entire heart is contracting. Now the pressures inside the heart is going to be super high. The pressures in the right atria is also going to be super high. Okay, entire ventricles and heart, the right atria are contracting at the same time. So the pressures in the heart are so much. Also the pressures in the internal jugular veins are so high. So that's why you can see here there are these canon A waves, sharp A waves. Okay, so the canon A waves are seen in those conditions of atrioventricular dissociation. Done. So now tell me, internal jugular venous pressures. How many waves are there? A, C, X, V, Y. You know, A wave is because of what? A wave, C wave, X wave, V wave, and Y wave. They're because of what? You already know this. Next, what you should know? Large A waves are seen in this one. Large A waves are seen in tricuspid stenosis, pulmonic stenosis. Absent A waves. Absent A waves are seen in atrial asystolic conditions like atrial fibrillation. Atrial fibrillation means atria are not contracting, just shivering like this, And canon A waves. The canon A waves are seen in AV dissociation, where atria and ventricles are contracting at the same time. Then you will have very sharp A waves called as the canon A waves. Next, repeatedly ask MCQ. No need, again I am saying you, no need to remember the graphs. Graphs are not needed. Sir, this was the question which was asked. If the patient is suffering with the tricuspid regurgitation, okay, tricuspid regurgitation, what kind of abnormality is seen in? Okay, what kind of abnormality is seen in jugular venous pressures? 3 abnormalities will be seen. Okay, 3 abnormalities. What are these 3 abnormalities? Now you can look here. See, tricuspid regurgitation. Okay, are you able to appreciate here? This is tricuspid regurgitation. In tricuspid regurgitation, there is blunted X descent. X wave, there is blunted X descent. And see, severe tricuspid regurgitation. Tall V waves are there. And again, in tricuspid regurgitation, there is prominent Y wave. Okay, sir, prominent Y descent is there. So what I am trying to put into your mind is, sir, this never ever forget this one thing. In tricuspid regurgitation, you will see 3 changes in the jugular venous pressures. 3 changes are there. What are these 3 changes? Tall V waves are seen. Blunted X descent. Tall V waves, blunted X descent, and a prominent Y wave. Okay, so now tell me, in tricuspid regurgitation, there is a tall V wave, blunted X descent, and a prominent Y descent. Okay, so these are the changes which are seen in tricuspid regurgitation. So with this, if you know this, 100% you can answer the MCQs regarding the jugular venous pressures also. So jugular venous pressures topic is also completed. A, C, X, V, Y waves and the abnormalities. Large A waves, canon A waves, absent A waves, and what are the changes you will see in tricuspid regurgitation? What are the changes? Tall V waves are seen, blunted X descent, and a prominent Y descent. Okay, these are the things which you will see. Okay, so now after this, what else you should know? See, regarding the other things, like, I will give you in the PDF. If you want to go through them, you can go through them, but not that important. The crazy question which was tested many times in the FMGE exam is, what is Kusumal sign? Kusumal breathing is different. Kusumal sign is different. What is Kusumal sign, sir? Okay, what is Kusumal sign? Kusumal sign, let's discuss now. Normally, listen, whenever you are taking deep inspiration or simple normal inspiration also. Whenever you are taking inspiration, let me write here. Explanation was given over there. You can like just go through the explanation once the PDF was is shared. Whenever you inspire, whenever you do inspiration, do you know what happens? Sir, inspiration, the jugular venous pressure JVP decreases. Okay, during inspiration, JVP decreases, sir. Then what is Kussmaul sign? So during inspiration, if JVP, jugular venous pressure, if it is not decreasing, okay, not decreasing, or if it is increasing, JVP is increasing, okay, JVP is not decreasing, or if JVP increases, then it is called as Kussmaul signs, and that's it. Okay, normally for understanding purpose I'm telling you, see, whenever I'm doing inspiration, what happened to my thoracic cavity? Thoracic cavity increases. Okay, whenever thoracic cavity increases, the negative pressure in the thorax, a negative pressure is generated. So this negative pressure, it will suck the blood from the jugular veins. It will suck down the blood from the jugular veins. So what happened to the jugular venous pressure during inspiration? Decreases. Blood is being sucked. No, the blood is being sucked to the right atria. So jugular venous pressure decreases. But what is Kussmaul sign? Kussmaul sign means during inspiration, the JVP is not getting decreased, or if it increases, rather if it increases, then it is called as a Kussmaul sign, which is an abnormality. What you should know for your exam? This Kussmaul sign is seen in which condition, sir? MCQ. This Kussmaul sign, it is seen in, at least for your exam, you should know these two things. There are conditions called as constrictive pericarditis and restrictive cardiomyopathy. In pathology, you will study these things. So, in constrictive pericarditis and in restrictive cardiomyopathy, in these two conditions, you will see Kussmaul sign. If you know this, enough. Okay, so restrictive cardiomyopathy and constrictive pericarditis, you will see Kussmaul sign. So completed. Next, after Kussmaul sign, what you should know, guys? Are you able to understand? Shoaib, Varun, Musawir, Sanjay, Da Vinci. I'm not like going through your comments, because if I go through your comment, it takes a little time. It takes a little extra time, so it will our session will be prolonged. I know this is a very important time for you. You need to cover many subjects, so that's why I'm not going through your comments regularly. Is it okay, guys? Okay. So at the end of the day, we have to cover all the important MCQs. That's it. Okay. Next, let's talk about the Frank-Starling law. Okay, Frank-Starling law. What is this Frank-Starling law? Okay. See, Frank-Starling law tells us the end-diastolic volume. You already know this. Okay, you know this. Already know this. Frank-Starling law. End-diastolic volume is directly proportional to the stroke volume. Sir, what is end-diastolic volume? You know the value. End-diastolic volume means how much blood is there in the heart. Okay, after relaxation, how much blood is going to be filled in the heart? How much blood is going to be filled in the heart, sir? Almost 120 to 140 ml. 120 to 140 ml is going to be filled in the heart. For example, if I fill 120 ml of blood, how much will come out? Out of this 120, 70 will come out. Out of 120, 70 will come out. Now, instead of filling 120, if I fill maybe 200, means what I have done? I have increased the end-diastolic volume. Do you think same 70 will come out? No, sir. If you put 120, if you put 200, maybe how much will come out? Maybe 140 will come out now, or maybe 150 will come out. Or for example, now if I increase, not 200, I am keeping here 250. How much will come out? Now maybe 180 will come out. Okay, maybe 180 will come out. So what I'm trying to put into your mind is, sir, if you increase the end-diastolic volume, see, if you increase the end-diastolic volume, see, EDV, automatically stroke volume is increased. The more you fill the heart, the more will come out. Or in an easy way, we can say something like this: the more you stretch the heart, the more powerfully it will contract, and more will be the stroke volume. Are you getting? So the more you put into the heart, more will come out. So end-diastolic volume is directly proportional to stroke volume. This is called as Frank-Starling's law. Okay, Frank-Starling law also completed. Next, after this Frank-Starling law, what else you should know? It's a fixed principle, sir. Fixed principle. A long back this question has been asked. Recently this question was not there in the exams, but anyway, it's a fixed principle is it's the estimation of the cardiac output. We know if I ask you what is the cardiac output, you will say 5 liters is the cardiac output, sir. Every minute our heart is beating and 5 liters of blood is getting pumped. Okay, it's getting circulated. But how to estimate whether it's 5 liters, 6 liters, 7 liters? How to estimate? By using a principle called as a fixed principle. So fixed principle, it's the estimation of, okay, it's the estimation of a cardiac output by the rate of oxygen consumption. By looking at how many marks you are getting, by looking at your progress card, I can estimate how good you are with your studies. In the same way, by looking at how much oxygen you are consuming, we can estimate what is your cardiac output. That is called as a fixed principle. Okay, so look here, the formula for this fixed principle is Q is equal to, Q means the cardiac output, Q is equal to VO2. Okay, Q is equal to VO2 means how much oxygen the person is consuming. Usually healthy individual will consume 250 ml of oxygen. That is a VO2 by arteriovenous oxygen difference. Okay, arteriovenous oxygen difference. So what is this arteriovenous oxygen difference? See, in the arterial blood, how much oxygen is there? 190 ml of oxygen is there. Per liter, 190 ml of oxygen is there per liter. And in venous blood, how much oxygen is there? Even in venous blood, oxygen is there. How much ml? 140 ml. Okay, 140 ml is there, sir. Simple. Okay, so in the arterial blood, 190 ml of oxygen is there. In venous blood, there is 140 ml. So minus, how much is the difference? 190 minus 140, 50 ml. 50 ml is the difference now. So 250 divided by 50, how much? 250 divided by 50 is 5 liters. Okay. So by looking at how much is the oxygen consumption, we can estimate the cardiac output. For example, see, now you get a cylinder, you get an oxygen cylinder. Say to me, okay, sir, I'm doing a treadmill test. Okay, I'm doing a treadmill test. I'm running or I'm sprinting. Okay, now you just get an oxygen cylinder. You just keep an oxygen cylinder to me. I'm just breathing through the oxygen cylinder. Okay, so that you can know how much oxygen I am consuming. For example, I have consumed 300 ml of oxygen. 300 ml of oxygen. My arteriovenous oxygen difference, it is constant 50. Okay, now tell me, what is the cardiac output? Okay, now my cardiac output is 6 liters. So by looking at the oxygen consumption, if you calculate the cardiac output, that's called as a fixed principle. Okay, so by fixed principle, we can calculate or we can estimate cardiac output. Okay, so VO2 divided by arteriovenous oxygen gradient, oxygen difference. Okay, concern. Now after this, what else you should know? The next concept which I want you to know is the baroreceptor reflex. Okay, baroreceptor reflex. Even before going to the baroreceptor reflex, see, we know what is the normal BP. The BP is 120 by 80. 120 by 80 is the BP. Okay. Now, what is the pulse pressure value? Pulse pressure. What is this pulse pressure? Pulse pressure is systolic BP minus diastolic BP. Systolic minus diastolic BP. Okay. So 120 divided, 120 minus 80. So it's a 40 mmHg. So pulse pressure value is, you know it. So pulse pressure is 40 mmHg. Okay, 40 mmHg. Next, one more pressure is there. That is called as a MAP, mean arterial pressure. So what is this mean arterial pressure? Mean arterial pressure, the formula is, for understanding purpose, let me tell you. Okay, for understanding purpose, see, 120 by 80, during systole the pressure is 120. During diastole the pressure is 80. See, don't tell me so many values. If you have to tell me one single value, you have to tell me an average value. Not 120, not 80, but in between value, like a mean value. Okay, so the mean arterial pressure is how much? The formula for this mean arterial pressure, is diastolic blood pressure, that is 80 plus 1/3 of the pulse pressure. You know the pulse pressure value. The pulse pressure is 40. How much is 1/3 of pulse pressure? 40 divided by 3. It is somewhere around 13. So 80 plus 13 is 93. Okay. So on an average, my blood pressure is 93 mmHg. Not 120, not 80. Average value 93. In between value 93. And what is the formula for mean arterial pressure? Diastolic blood pressure plus 1/3 of the pulse pressure will give you mean arterial pressure. And now the topic which I want you to know is the baroreceptor reflex. So baroreceptor reflex. What is this baroreceptor reflex and what you should know for your exam? Okay, so we are almost like at the end of the cardiovascular system. This with this and with some other reflexes we can complete the cardiovascular system. We are at the end. So same. My mean arterial pressure is how much? It is 93 and it should be maintained all the time. Okay, 93 mm Hg mean arterial pressure. Who is maintaining this mean arterial pressure? Who is checking this mean arterial pressure all the time? See, there are receptors called as a baroreceptors. Okay, there are receptors called as a baroreceptors. And where do these baroreceptors are present? So these baroreceptors, they are present in an area called as common carotid, a carotid sinus. There is an area called as a carotid sinus. Okay, and in the arch of aorta, this is the aorta, right? So in the aorta and in the carotid sinus, there is an area called as a carotid sinus. In these two areas, these baroreceptors are present. And what are these baroreceptors? They are all the time measuring, what is the mean arterial pressure? How much is the mean arterial pressure? Is it 93 or not? It's maintaining, it's all the time getting checked. And this information, look here, what I'm trying to put into your mind is, sir, here what do you have? You are having the aortic baroreceptors. Okay. And what is here? There is, these are carotid baroreceptors, aortic baroreceptors and carotid baroreceptors. And what they are checking? They are sensitive to what? They are sensitive to mean arterial pressure, not systolic blood pressure, not diastolic blood pressure. They are sensitive to mean arterial pressure. Now, mean arterial pressure, it is going to 140. From 93, it is going to 140. Is it good? Definitely not. From 93, it is coming down to 70. It's coming down to 60. Is it good? Definitely not. So now the BP need to be regulated. There should be a reflux which is all the time regulating the mean arterial pressure or the BP. How it will happen? Let me tell you. So first, normally all the time information about this mean arterial pressure is going where? It is going to the central nervous system. Via which nerve? Via the 9th cranial nerve. That is a Herring's nerve, a branch of 9th cranial nerve, a branch of 9th cranial nerve. It's a Herring's nerve, a branch of 10th cranial nerve called as the Science nerve. So via the Herring's nerve and Science nerve, the information is going where? See, the information is going to nucleus of tractus solitarius, okay, which is present in the medulla. Okay, so now tell me, what are the receptors? Receptors are the carotid baroreceptors and the aortic baroreceptors. Information is going about the BP, information is going to the central nervous system. To which nucleus? The nucleus is called as the nucleus of tractus solitarius. Okay, it's NTS. The nucleus of tractus solitarius, which is present in the medulla. Information is going via the 9th cranial nerve and 10th cranial nerve. That is the Herring's nerve and Science nerve. Okay, and these baroreceptors, aortic baroreceptor, carotid baroreceptor, they are sensitive to what? They are sensitive to mean arterial pressure. They are sensitive in this mean arterial pressure range. They will work and they will give the information. Okay, so now information is going. The central nervous system, nucleus of tractus solitarius, is all the time checking what is the mean arterial pressure. Now look here. Now mean arterial pressure is increasing. For example, MAP, mean arterial pressure increased. Now you are having a fight with your girlfriend. Now your mean arterial pressure is increased. Your BP is increasing. Now what will happen? See, the carotid baroreceptors and the aortic baroreceptors, now they are activated due to increase in BP. Now this information is going to the central nervous system via the 9th cranial nerve and 10th cranial nerve. See, 9th cranial nerve and 10th cranial nerve, now they are exciting. And information is going where? Information is going to nucleus of tractus solitarius. Okay. Now what this nucleus of tractus solitarius, what it will do? Our problem is more BP, high BP. Do you know what this nucleus of tractus solitarius, what it will do? At the end of the day, I am not going in detail, I am simply telling you. So this nucleus of tractus solitarius, what it is doing? It is activating, okay, it's activating the parasympathetic nervous system, the vagal, see, excites the vagal neuron, means the parasympathetic nervous system is being activated. So when the parasympathetic nervous system activates, what happens? Their heart rate decreases. automatically BP decreases. The same nucleus of tractus solitarius, what it is doing? So the sympathetic activity is decreasing. So sympathetic nervous system activity will be reduced. So again, what happened to the heart rate? Heart rate decreases. If heart rate decreases, what happened to the BP? BP decreases automatically. So what I am putting in your mind is, sir, there is this reflex happening whenever you increase the BP. Suddenly now, if you increase the BP, automatically my heart rate will come down. After that, BP will also come down. Okay, so it's a reflex trying to protect my body. Okay, trying to protect my blood vessels and to keep the blood in the circulation. Okay, so whenever you increase the BP, nucleus of tractus solitarius, this medullary center, the nucleus of tractus solitarius, it will understand, array, mean arterial pressure is getting increased. So what it will do? It activates the parasympathetic nervous system, decreases the heart rate and decreases the BP. And not only that, this nucleus of tractus solitarius, it inhibits the sympathetic nervous system. Inhibition of the sympathetic nervous system decreases the heart rate and BP decreases. Okay, if sympathetic nervous system is getting inhibited, means also the blood vessels will undergo relaxation. BP decreases. BP decreases. Okay, so here comes one important law. If you increase the BP, what is happening to heart rate? Increase in BP causes reflux decrease in heart rate. If you increase the BP, there is a reflux decrease in heart rate. Can you tell me what is this law? Okay, now I am giving you a chance. Can you tell me what is this law, guys? Increase in BP decreases the heart rate. What is this law called as? This is called as Mary's law. Okay, so done, sir. Mary's law states as if you increase the BP, automatically heart rates comes down. Mary's law also completed. Now, after this, what else you should know? The next MCQ point which I want you to know is if you do carotid sinus massage. Okay, you are doing the carotid sinus massage, which means you are compressing the carotid sinus. See, the carotid sinus is there, no? It is the blood vessel. It is getting compressed. When you are compressing the carotid sinus, what your nucleus of tractus solitarius will think? Or if you are compressing a blood vessel, locally here, only here, the blood pressure is increasing because of the external pressure. Okay, because of the external compression, the carotid sinus is getting compressed. So now tell me the carotid baroreceptors. Okay, so carotid baroreceptors are activated. Now these carotid baroreceptors are activating which cranial nerve? Ninth cranial nerve. This ninth cranial nerve, what it will do? It will take the information to nucleus of tractus solitarius. This nucleus of tractus solitarius, what it will do? It will activate parasympathetic nervous system. When the parasympathetic nervous system is activated, what happened to heart rate? Heart rate comes down. So that's what. So whenever you do a carotid sinus massage, first heart rate comes down. The decrease in heart rate will further later. Okay, later decreases the BP. Okay, this decrease in heart rate, it will decreases the BP. Okay, so that's why whenever if a patient is having severe hypertension, now simply do the carotid sinus massage. When you do the carotid sinus massage, heart rate decreases followed by BP decrease. Okay, so MCQ, carotid sinus massage MCQ is also completed. Now, after this, what else you should know? Reflexes, sir. Reflexes. Simply I am telling you, you don't need to go through this entire big table. 3 reflexes are there. Okay, 3 reflexes. One is Cushing's reflex. Cushing's reflex. Okay, Cushing's reflex, the first reflex. Second reflex is Bain-Bridge reflex. And the third reflex is Bezold-Jarisch reflex. Sir, first remember all the cardiac reflexes. Baroreceptor reflex, you know. 9th cranial nerve, 10th cranial nerve, Herring's nerve, Sands nerve. Okay, carotid baroreceptors, aortic baroreceptors, you know all this stuff. Okay, you know about this. The Cushing's reflex, all the cardiac reflexes, they are bradycardic reflexes only. At the end of the day, heart rate decreases. Okay, heart rate decreases. Bezold-Jarisch reflex, heart rate decreases. But remember, the one reflex which I want you to know, Bain-Bridge reflex. So this Bain-Bridge reflex is the one exception. It is a tachycardic reflex. Means heart rate increases because of this reflex. heart rate increases. That's the question which will come in your exams. All the cardiac reflexes are the bradycardic reflexes. They will decrease the heart rate. But which is the tachycardic reflex? It's a Bainbridge reflex. Bainbridge reflex. Now, what you should know about regarding these reflexes? See, first one, Cushing reflex. If you increase the intracranial pressure because of some reason, man, simple. If you increase, there is some head trauma. That head trauma is increasing the intracranial pressure. Okay, intracranial pressure is increased. When intracranial pressure increases, at the end of the day, that will cause vagal stimulation. Why? This is not the time. There is a there is a whole reflex pathway. What happens? I'm not going in detail. Simply, whenever the intracranial pressure increases because of some reason, say head injury happened, increase intracranial pressure. At the end of the day, do you know what happens? Vagal tone is increased. That, do you know what it will do? So because of this vagal tone, increase in the vagal tone, heart rate decreases. So that's why Cushing's reflex. Look here. The point which I want you to know is Cushing reflex is seen in the conditions where intracranial pressure is increased. When the intracranial pressure is increased, the vagus nerve is activated. When the vagus nerve is activated, vagus is a parasympathetic nerve. It's a parasympathetic nerve, right? So what it will do, it decreases the heart rate. Simple. Okay. And second one, Bainbridge reflex. I used to remember something like this. For example, you are like standing on a tall bridge. Okay, tall bridge. Now, on that bridge, you are like standing and you are looking down into an abyss. Okay, you are looking down into a cave or abyss. Automatically, you will feel frightened, right? You will feel scary. What happened to your heart rate? Heart rate increases. So remember it like that. It's like a mnemonic. The Bainbridge when you are standing on a top of the bridge, your heart rate increases. So Bainbridge reflex is an example of tachycardic reflex. Heart rate increases. Okay, but why, sir? Why? When you will see this Bainbridge reflex, when means, see, when you increase the volume, okay, when you increase the volume of blood, simple, and I'm putting in a simple way. Simple, answer my question, this thing. I'm giving you the saline infusion. Okay, I'm giving you the saline infusion. Means I'm injecting the saline into your body. What happened to your blood volume? Your blood volume increases. When you are having more blood volume, tell me, your heart should work more, right? Simple. When you increase the blood volume, heart rate will increase, sir. Simple, that's it. So Bainbridge reflex is seen in those conditions where the blood volume is increasing. When you increase the blood volume, heart rate increases. The heart will work more. Simple, that's a Bainbridge reflex. Okay, next, Basal-Jarvis reflex. See, Basal-Jarvis reflex means because of certain chemicals. Okay, because of certain chemicals like serotonin, capsaicin, like if you put certain chemicals into the heart or if you put certain chemicals into the blood, these chemicals will decrease the heart rate. Okay, so that's why it's a chemo reflex, like something like a chemical regulated thing. That's why, see, even here also, if you see Bainbridge reflex, Basal-Jarvis reflex. Basal-Jarvis reflex, see, it's a chemosensitive. Means if you put certain chemicals into the heart, these chemicals will actually decrease the heart rate. Okay, so anyway, guys, I don't want to go through all these things right now. Only important point: Bainbridge reflex is a tachycardic reflex. Basal-Jarvis reflex is the bradycardic reflex. Cushing reflex is again a bradycardic reflex. Cushing reflex is seen due to increased intracranial pressure. Vagal tone is increased. Heart rate decreases. Okay, heart rate decreases. All the reflexes are bradycardic reflexes except Bainbridge reflex. On the bridge, you will have tachycardia. Okay, so after this, what you should know? Next, the point which I want you to know is, sir, this was a question asked in 2019 FMGE exam. Okay, 2019 FMGE exam, 2017 FMGE exam. This 2019 and 2017 FMGE exam, these questions has been asked. What are these questions, sir? I'm concentrating only those questions. Now imagine there is a blood vessel. Okay, even before that, let me tell you about the Poiseuille-Huygens formula. See, what is Poiseuille-Huygens formula? Simple. Blood flow, the relationship between blood flow, how a blood is moving fastly or slowly. Blood flow, relationship in blood flow and pressure difference across the blood vessel. radius of the blood vessel, length of the blood vessel, and viscosity of the blood vessel. Don't worry, we'll explain in a simple way. For example, see here, this Poisson-Huygens formula is telling us blood flow, it is directly proportional to, means blood flow increases with what? Blood flow is directly proportional to the pressure difference, pressure gradient. Blood flow is directly proportional to the radius of the blood vessel, and blood flow is inversely, blood flow decreases, the velocity of the blood flow, the speed of the blood flow decreases if the length of the blood vessel increases. Blood flow is inversely proportional to viscosity. If the blood viscosity, the thickness of the fluid, if it is more, if the viscosity of the blood is more, blood flow will be, the velocity of the blood will be less. Or for example, say, now let's take a condition called as a polycythemia. Polycythemia. What is polycythemia? More RBCs are there, more hemoglobin, more RBCs there. Now what happened to the viscosity of the blood? Thick blood, sir, thick blood. Do you think this blood will move faster with high velocity? No. So velocity of the blood or the blood flow, it is inversely proportional to viscosity, inversely proportional to the length of the blood vessel. More the length of the blood vessel, more friction will be there. So less speed, less blood flow will be there. Okay. Now look here and answer this. Now imagine there is this one blood vessel A. Okay, blood vessel A. Now this is point number, okay sir, point number A and point number B. This is the first blood vessel number 1. Now this is the blood vessel number 2. Again I am showing you, look here. See the pressure at the point number A is 100 mmHg. The pressure at the point number B is 99 mmHg. In the second given example, look, the pressure at the point number A is 100 mmHg. At the point number B, the pressure is just 1 mmHg. Now tell me, in which blood vessels blood will move? In which blood vessels the blood flow will be more? First of all, in case number 1, blood flow will be there or not? Sir, here the pressure is 100 and this point number B, at this point, one end and the other end. At the other end, the pressure is 99 mmHg. Will the blood move or not? Yes sir, the blood will definitely move. Why? Because there is a pressure difference, high pressure to low pressure. But how much is the pressure difference? How much is the gradient, sir? The pressure difference is only 1 mmHg. Yes, blood will move, but low, less blood flow, less blood flow will be there. But when compared to first one, second one, here it is 100 mmHg, here it is just only 1 mmHg. So the gradient, how much? How much is the delta P? The gradient is 99 mmHg. Okay, the gradient is 99 mmHg, sir. So the more blood flow will be there. So that's why the blood flow is dependent on the blood flow is dependent on what? The blood flow is dependent on the pressure gradient. That's the first thing. Okay, blood flow is dependent on the pressure gradient. Now, second, look at this second thing. So blood flow is also directly proportional to the radius to the power of 4. So what is this radius to the power of 4? Look at here. Now imagine this is a blood vessel. Okay, this is a blood vessel. Now you have dilated the blood vessel. Now more blood flow will be there or not? Yes, more blood flow will be there. If you double the radius, for example, say, if you double the radius, blood flow will be doubled? No, blood flow is not doubled. Radius to the power of 4, which means, now look here, according to the Poisson-Huygens formula, what we have discussed, see, if the radius of the blood vessel, if it is doubled, what happened to blood flow? We know according to the formula, blood flow is directly proportional to radius to the power of 4. If you double the radius, see, look here, you double the radius, means 2. In the place of radius, I am keeping 2, means I am doubling the radius, I am 2 times increasing the radius. Say 2 to the power of 4, how much? 2 into 2 into 2 into 2, 16. Okay, so 16 times blood flow increases. Okay, now what you should know is, if you double the radius, blood flow is not going to be doubled. Rather, blood flow increases by 16 times. There is 16 times more blood flow. That's the important point. Okay, so blood flow increases by 16 times. For example, look here. If the radius of the blood vessel, if it is tripled, if you triple the radius, how many times the blood flow increases? So 3 to the power of 4, 3 to the power of 4, 81. So 81 times the blood vessel increases. Okay, so you should know these things. If the blood vessel radius is doubled, 16 times there is more blood flow. If the blood vessel radius, if it is triple, there is 81 times more blood flow. Completed. So with this, the cardiovascular thing is completed. Now, as a part of cardiovascular thing, it's not exactly the cardiovascular thing, but it comes under the blood. Now, this was the question asked in the recent FMGE exam which has happened. Okay, in the recent FMGE exam, this question was asked. Okay, now, guys, I hope you already know this, but I am not sure whether you have gone through this or not. In pathology, this will come again. In physiology, also this will come. So, the topic which I am going to discuss here is the clotting cascade. How clotting will occur? The clotting cascade, sir. Okay. Now, to make the things easier, I will just show you. See, in a simple way. And how many clotting factors are there? Just concentrate for the next 5 minutes. You'll answer the questions like this. You can answer just questions like this. Okay. How many clotting factors are there? 12 clotting factors are there. 12 clotting. Actually, 13 are there. But 6th clotting factor is missing. So, always write 10 in the middle. Okay. Always write 10 in the middle. Okay, otherwise it will be very difficult. You will study about the intrinsic pathway, extrinsic pathway, common pathway. So many things are there. Concentrate for 5 minutes, you will understand for sure. Okay, see, this is 10, clotting factor number 10. Now, after writing this 10 in the middle, now tell me, how many clotting factors are there? 12 clotting factors, sir. 12, okay. After 12, before 12, what is the number? Before the 12, 11. Okay, so before 11, what is the number? 10 is there, which was already written over there. Okay, which was already written over there. So before 10, what is the number? Before 10, the number is 9. Before 9, what is the number? 8. Before number, what is the number? Before 8, what is the number? 7. Okay, write 7 on this side. Okay, so 12, 11, 9, 8. And on the other side, 7 and 10. Now tell me, 5 2s are how much? Okay, see, before 7 there is no 6. Before 7 there is no 6. Forget about the 6. I'm just generally asking 5 2s are how much? 5 2s are 10, sir. So right, I'm just showing you 5 into 2, sir. 5 2, sir. 10, sir. 5 2. 5 into 2 into 1 also 10 only, no? 5 into 2 into 1. 5 2s into 1. So sir, same thing, 10 thing. So here I have completed. Okay, I have completed the intrinsic pathway as well as the extrinsic pathways. Look here. Sorry, yeah. So this side, on this side, what I'm showing you, this clotting factor number 12, 11, 9, 8. See, 12 will activate. Once if 12 is activated, 12 activates 11, 11 activates 9, 9 activates 8, 8 activates 10. So this pathway which I have shown till 8, this is the intrinsic pathway, IP, intrinsic pathway. This pathway is called as the intrinsic pathway. And this pathway which I am showing you, 7 from this side, this is called as the extrinsic pathway. Intrinsic pathway and extrinsic pathway. Okay, and what is this 10, 5, 2, 1? This, the middle things, this 10, 5, 2, 1. This pathway is called as common pathway. Simple. That's it. So extrinsic pathway, intrinsic pathway, common pathway. Do you know what is like, sir, we can't understand what is happening exactly over here. Simple. First 12 will be activated, 12 activates 11, 11 activates 9, 9 activates 8, 8 activates 10, 10 activates 5, 5 activates 2, 2 is going to, do you know what this 2 will do? So 2 is going to convert, okay, let me show you. This 1 means, activation of 1 means nothing but, so this clotting factor number 2, which is the prothrombin, do you know what it will do? It will convert fibrinogen, soluble fibrinogen, the clotting factor number 1, which is soluble in form. Soluble fibrinogen into insoluble fibrin. Soluble fibrinogen will be converted into insoluble fibrin. So that's it. Clotting completed. Fibrin. Now it is not soluble. It is now total in the form of strands. Now it's total in the form of the strands, sir. Total in the form of the strands. Fibrin strands. Clot is formed. And that's it. So now tell me, 12, 11, 9, 8 are the intrinsic clotting factors which are involved in the intrinsic pathway, and 7 is involved in the extrinsic pathway. And what are the clotting factors which are involved in the common pathway? 10, 5, 2, 1. Now, if you are a really good student, you should have a doubt. Sir, one clotting factor is missing. Can you tell me what is that one clotting factor which is missing? Mainly 3, sir. 3. So where is that 3? Like, where we have to fit that 3 here? Let me tell you. Okay. First of all, why we are calling this as an intrinsic pathway? Intrinsic, something within the blood. Whenever there is a damage to blood vessel, The subendothelial collagen will be there, no? Something inside the blood vessel only. The subendothelial collagens, subendothelial collagens, it will activate the clotting factor number 12. Now you will get it out. Who will activate clotting factor number 12, sir? So whenever there is a damage to blood vessel, the subendothelial collagen, it will come into contact. It will come into contact with the clotting factor number 12, activates clotting factor number 12. 12 activates 7, you know the story. Okay, so that's why it is called as intrinsic pathway. Something intrinsic to the blood vessel is triggering the clotting cascade, it is stimulating the clotting cascade. Okay, so then why it is called as extrinsic pathway, this 7 and 10? Why? Because see, whenever there is any damage, trauma here, whenever there is any trauma, not only the blood vessel is damaged, but surrounding tissue is also damaged, no? So from the tissue, there is something called as tissue factor. Tissue factor, also called as tissue thromboplastin. Tissue factor or tissue thromboplastin is getting leaked from the tissues. This is getting leaked from the tissues. This is also called as tissue factor, is also called as clotting factor number 3. Clotting factor number 3. So this clotting factor number 3, it will activate 7. Okay, from where this 3 is coming? From the tissues. 3 will activate 7. 7 will activate 10. Okay, so that's the point. 3 will activate 7, 7 will activate 10. So now tell me, this was the question asked in the FMGE exam. Which of the following is which of the following protein is involved in extrinsic pathway? 3 and 7. Which of the following clotting proteins are involved in intrinsic pathway? 12, 11, 9, 8. Which of the following proteins are involved in common pathway? 10, 5, 2, 1. What is the last step in clotting cascade? Conversion of soluble fibrinogen into insoluble fibrin. Done. Done. That's it. So, if you know this, that's more than enough. And one point if you want to know, so this clotting, this intrinsic pathway and extrinsic pathway, they are studied by timings. Only, like, you know, that I hope you already know. So this is a big pathway, right? So you have to give the bigger name. Do you know what are the studies called as the timing? Clotting timing is measured by PT and PTT. So this is a bigger pathway. I am giving bigger name PTT. This is a smaller pathway, so I am giving the smaller name PT. So PT, prothrombin time. PT for prothrombin time. PT measures which pathway? Tell me. Sir, PT is the time measuring the extrinsic pathway. Then PTT is measuring the time for which pathway? PTT. PTT is measuring intrinsic pathway. Simple. If I ask you, see the question like this. Deficiency of factor number 8. Deficiency of factor number 8. It will increase the time of PT or PTT. It will cause, like, no, it will increase the time of PT or PTT. Sir, 8 is a clotting factor which is involved in the intrinsic pathway. So PTT time will be elevated. PTT will take now it will like a lot of time for the intrinsic pathway to occur. It will take a lot of time. So PTT will be elevated. Okay. So this is the point which I want you to know. So completed, guys. Completed. So this is the thing which I want you to know. So done, sir. Now one more thing for your exams which I want you to know is, sir, have you ever heard about vitamin K? Vitamin K. We'll take a break now. Have you ever heard about vitamin K? So vitamin K, it is needed from biochemistry especially. It is needed for activation of which clotting factors? Vitamin K, it is needed for the activation of 2, 7, 9, 10. 2, 7, 9, 10. So clotting factor number 2, 7, 9, 10. These clotting factors. For their activation, for their working, for the activation of the 2, 7, 9, 10, you need to have vitamin K. Okay, that's the MCQ. Okay. So that's the one point which I want you to know. Vitamin K is needed for the gamma carboxylation activation. I'm just using the word activation, but it is actually vitamin K. There is a vitamin K with the help of an enzyme called as vitamin K epoxide reductase will cause gamma carboxylation of 2, 7, 9, 10. In a simple way, you can say vitamin K is needed for the activation of 2, 7, 9, 10. Done. Can you tell me, there is a drug which will cause inactivation of this vitamin K epoxide reductase? See, there is a drug called as warfarin. In our FMGE exam, these questions were repeatedly asked. We repeatedly tested. So there is a drug called as warfarin. What it will do? It will inhibit an enzyme. It will inhibit an enzyme which is called as vitamin K epoxide reductase. Okay, so vitamin K epoxide reductase enzyme is inhibited. So gamma carboxylation, okay, gamma carboxylation of 2, 7, 9, 10 clotting factors does not occur. Okay, so remember, in war what we will do? Killing, right? In war we will do killing. So that the same way, sir, in warfarin, who will be affected? Vitamin K, K for killing. Vitamin K epoxide reductase is inhibited. So 2, 7, 9, 10 factors are not activated. So that's the reason why we will call this warfarin as anti-clotting factor. It's like an anti-clotting, right? Warfarin is, so it prevents the clot. It's anticoagulant. It's an anticoagulant. Prevents the clot. How? If you take warfarin, vitamin K epoxide reductase is inhibited. Factor number 2, 7, 9, 10 are not activated. So do you think clotting will happen now? No, there is no clotting. There is no clot. There is no. Okay, there is no clotting. Okay, so this is also completed. Intrinsic pathway, extrinsic pathway here, same is also completed. So okay, guys. So now shall we take a break? Now I have integrated so many things. I have discussed all the important concepts. If you go through these concepts, that's more than enough. Okay, you will nowhere find all the important concepts in one single place. Okay, just go through this, more than enough. I'm telling you. Okay, shall we take a break for now? Shall we take a break of 5 minutes? In 5 minutes, we'll take a break and later we'll continue with the new concepts. Is everything clear, guys? Divya Prakash, Naimat, Varun, Suleiman. If you have any doubt, you can ask me. Okay, so just even before giving the break, just I'm asking you 2-3 questions I will ask you. You just try to answer yourself. Okay, sir, in tricuspid regurgitation. Okay, in tricuspid regurgitation, what kind of jugular venous pressure waves, what kind of abnormalities are seen? What kind of changes? What kind of changes that you will see in JVP waves? Sir, in tricuspid regurgitation, 3 things are seen. What are they? Answer: tall V waves, blunted X descent, and a prominent Y descent. Okay. Holosystolic murmur. Holosystolic throughout the systole, not throughout the systole and diastole only. Holosystolic murmur or pansystolic murmur is seen in mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. Ventricular septal defect. Continuous machinery murmur. Continuous machinery murmur, both during systole as well as diastole. Patent ductus arteriosus. Okay, like if you ever see such a kind of, if you ever see such a kind of left ventricular pressure volume loop, such a kind of left ventricular pressure volume loop, tall thing. What is this one? Aortic stenosis. Aortic stenosis. Okay, whenever you see such a kind of left ventricular pressure volume loop, both extending from that side to this side, where the stroke volume is more, which is showing more. What is this one? This is mitral regurgitation. Mitral regurgitation. Okay, these kind of things. Okay. Okay, you want, someone is asking me to explain preload and afterload. Yes, after the break, I will explain simply what is preload and afterload. After the break, I will explain. Let's take a break of 5 minutes. Okay, guys, we'll meet after 5 minutes. Okay, welcome back, guys. Now, someone is asking about the preload, but afterload, right? Okay. See, preload and afterload. See, preload is nothing but, see, first of all, preload is nothing but end diastolic volume. We have said, right, that 120 ml of blood, that 120 to 140 ml of the blood, how the amount of blood that's going to stay in the ventricles, the amount of blood that's going to come into the ventricles during diastole, means during diastole or during relaxation, how much blood is going to be there inside the ventricles. It is called as the end diastolic volume. It's nothing but the preload. End diastolic volume, preload, they are all one the same. Okay, so this preload and end diastolic volume, they are the same things. MCQ which you need to know is, if you want to know in the MCQ point of view, so preload, it depends on what? Depends on venous return. Venous return. So preload depends on venous return. For example, now let's understand like this. If there is vasoconstriction, now I'm using a drug called as vasoconstrictant. Now I'm doing vasoconstriction. Especially which vessels? Veins. Okay, so let's write that venoconstrictor. I'm using a drug called as venoconstrictor. When your veins in the legs, when your veins in the lower extremities, whenever they are constricted, whenever they're compressed, what will happen? More blood is going to come to the heart. More blood is coming means more blood is going to be filled into the heart. So simple. So if you do venoconstriction, what happens? Sir, venous return increases. When venous return increases, more filling of the heart will happen. So what happened to the end diastolic volume? End diastolic volume increases. When end diastolic volume increases, it's nothing but, yes, preload increases. Its preload increases. Okay, more the blood in the heart, more load on the heart. Simple. If you keep 120 ml of blood, then preload. That's a normal preload. If you give 150 or 160, 180 ml of blood, 180 ml of blood, you are increasing the load on the heart. So you are increasing the preload. That's a load on the heart. The load on which the heart is working, the load on which the heart is acting is called as a preload. So preload is nothing but the blood, amount of blood which is staying in the heart. Okay. Now, what is afterload? Afterload is a load against which the heart is working. For example, to make you understand in a simple way, see, this is the left ventricle. I'm talking about the left ventricle. From the left ventricle, who is coming out? What is this blood vessel? So this blood vessel is the aorta. Okay. Now, look here. Now this aorta, it is divided into what? So this aorta is going to divide into arteries. Now this arteries, they are going to further divide into arterioles, something like this. What are these? These are the arterioles, right? Arteries are further divided into arterioles. Now my question to you. Okay, this is also very important MCQ actually. See, this is aorta. Now what is this wall? Can you tell me? So this wall is aortic wall. Now usually in your aorta, what is the pressure? All the time in your aorta, the pressure is 80 mmHg. 80 mmHg. Let's take it as a base value, 80 mmHg. Okay. So now this left ventricle, how much it should generate the pressure to open this aortic wall? To open this aortic wall, the left ventricle have to generate now the pressure of more than 80 mmHg, like 80.1 it have to generate. Okay, are you getting it? So now left ventricle have to generate a pressure of 80.1 or 81 mmHg in a simple way. Okay. Now my question is saying, you will understand, for lifelong you have to know this. So these arterioles are there, right? These arterioles are totally surrounded by, they are having highest concentration of smooth muscle. These arterioles, what they are having highest concentration of smooth muscle. Okay. Okay. Now, because of the smooth muscle activity, now arterioles are constricted. Now let's take an understanding like this. Arterioconstriction. Arterioles are constricted. Arterioconstriction. Arterioles are constricted. Now when the arterioles are, they're totally constricted. Now tell me, when the arterioles are constricted, Do you think the blood can move forward easily? Now, do you think the blood from the aorta into the arteries to the organs, do you think it will move easily? No, sir. The blood cannot move easily forward. So, what happened to the pressure in the aorta? The pressure in the aorta now is not just 80 mmHg. Now it will increase. Now, baseline pressure, now it will increase to maybe 120 mmHg. Now, left ventricle, see, now left ventricle to open this aortic wall, how much pressure it have to generate? That the left ventricle, now it have to work more. Now it have to generate a pressure of now 121. Okay. For example, now if you think that the pressure in the aorta, now the pressure in the aorta is maybe 150 mmHg. Now how much left ventricle have to generate? Left ventricle have to generate a pressure of 151. So more the pressure in the aorta, more pressure the left ventricle have to generate, the more work it have to do, the more load is there on the, now more load is there on the left ventricle. More load in the sense it have to work more. So this is called as afterload. So afterload, it is nothing but aortic pressure. Or in a way we can say afterload is nothing but the pressure generated by the left ventricle. How much pressure the left ventricle is need to generate. How much pressure the left ventricle need to generate to open the aortic wall. That's called as the afterload, sir. Simple. Now tell me, afterload is dependent on what? So the pressure in this aorta, okay, the pressure in this aorta, it is dependent on what? The pressure in the aorta is dependent on whether the arterioles are constricted or dilated. Okay, now this is the MCQ. Preload depends on, see, here I have already shown you. Preload, it depends on venous return. More the venous return, more preload. But what about the afterload? Afterload depends on the resistance of the blood vessels. These arterioles, when they are, whether they are constricted or dilated. This is called as total peripheral resistance. Okay, so TPR. Afterload, it is dependent on what? It depends on the total peripheral resistance, whether the arterioles are constricted or dilated. Now, the question can come something like this also. So, this TPR is maximum for which blood vessels? So, the TPR is maximum for which blood vessels? Arterioles. Why? Why arterioles? Why? Because arterioles have maximum smooth muscles. Okay, so now remember, arterioles are having maximum smooth muscles. So there will be arterioconstriction, arteriolodilation. Based on arterioconstriction, arteriolodilation, afterload changes. Okay, total peripheral resistance changes. When total peripheral resistance changes, afterload also changes. So afterload is nothing but, I'm telling you, see, afterload is nothing but the pressure which is generated by the left ventricle in order to open the aortic wall. And it depends on what? It depends on arterioles mainly, whether the arterioles are constricted or dilated. Okay, now I will give you one example. You please tell me. See here, this is your left ventricle. This is your LV, left ventricle. And what is this? Aorta. After the aorta, what do you have? These are the arteries. After the arteries, what do you have? See, these are the arterioles. Now, in this given example, the arterioles, they are not constricted. Now, arterioles are absolutely dilated. Okay, now arterioles, they are not constricted. They are dilated. Now, they are like this. Now, whenever they are dilated, whatever the blood is there, it's not staying. It's simply going easily in the forward direction. The blood is not being stagnated. It's not getting congested. So, now when the blood is now moving very easily, now what happened to the pressure in the aorta? The pressure in the aorta decreases. Now the pressure in the aorta may be just 70 mmHg. Now, what about the afterload? Now tell me, what about the afterload? Now, left ventricle just need to generate 71 mmHg. 71 mmHg, simple. No need to even generate 80, just 71 is enough. So, what I'm trying to put into your mind is, afterload is nothing but the pressure generated by the left ventricle to open the aortic wall. Okay, so is that clear? Hope that's clear. Now, let's continue with the endocrine system. The target is in the next half an hour. in the next half an hour or maximum to maximum next, like, maximum 40 minutes. Let's complete the endocrine physiology. From here, everything is going to be easy. Now, tell me. So here I am showing you this gland, which I am showing you is the pituitary gland. Now in the pituitary gland, how many lobes are there? There is anterior pituitary as well as posterior pituitary. Anterior pituitary, it is developed from Rathke's pouch. Anatomy MCQ, you need to know. Okay, anterior pituitary, it is derived from the Rathke's pouch, and the posterior pituitary, it is derived from the neuroectoderm. Okay, done. And see, in an adult, okay, this Rathke's pouch, if still this Rathke's pouch cells are there, and if they forms a tumor, then it is called as craniopharyngioma, MCQ, from the pathology point of view. Tumor to the remnants of Rathke's pouch, that will cause, like, a tumor. This tumor that is coming from the Rathke's pouch is called as a craniopharyngioma. Okay, done. After this, what I need to teach you in the anterior pituitary. Okay, here, let me show you here. See, this is hypothalamus. Now, what is this? This is the anterior pituitary. Now, in the anterior pituitary, there are different types of cells are there. For example, look here. There are 5 different types of cells are there. There are somatotropes. The color coding is very much important. Specifically, there is a reason why I am just showing the colors like this. Somatotrope, lactotropes. And what are these? These are corticotropes, thyrotropes, and gonadotropes. Now, see, the question which they will ask you in your exam. Very, very important question. If you stain the cells in the anterior pituitary, you take a tissue from the anterior pituitary and you stain those cells. See, 2 cells are taking red color stain. These are called as acidophilic cells. So, which cells are acidophilic cells? Which cells will take the eosin stain? Are eosinophilic, acidophilic, not the basophilic. Which cells are eosinophilic or which cells are acidophilic cells? Say somatotropes and lactotropes. Somatotropes produces the growth hormone. Lactotropes produces the prolactin. So these cells are the acidophilic cells. So the same thing which was shown over here, the acidophilic cells, somatotropes and lactotropes. Okay. So that's the reason why these hormones are also called as growth hormone and prolactin. They are coming from the acidophilic cells, and they are also called as the growth. They are also called as the twin hormones. Okay, they are also called as the twin hormones. Do you know the reason why they are called as the twin hormones? The reason is, see, both is prolactin coming from the lactotropes, and this growth hormone coming from the gonadotropes. See, these two, prolactin and growth hormone, they use one kind of receptor called as the tyrosine kinase receptor. Okay, tyrosine kinase receptors. Again, MCQ from the physiology. Okay, again this will come in even in the general physiology also when I teach in the second half. Again, there I will like tell you this. I will explain you this. So there are these hormones called as the pig hormones. What are these pig hormones? Prolactin, insulin, growth hormone. So these pig hormones, these 3 hormones, they will use a same type of receptor. What is the type of receptor called as? That receptor is called as a tyrosine kinase receptor. All these 3 will use the tyrosine kinase receptor. Come on, guys, please tell me. Acidophilic cells. What are the acidophilic cells? The acidophilic cells are acidophilic cells are the lactotropes as well as the somatotropes. These are the acidophilic cells. And why they are called as the twin hormones? The growth hormone, prolactin, they are called as the twin hormones. Why they are called as twin hormones? Because they use the same type of receptor. Done? Okay. Now after this, what else you should know? The very, very important point which I want you to know is, see, let me draw here itself. Let me draw here. Now let's understand this as a hypothalamus. You guys already know this. This is the hypothalamus and this is the anterior pituitary. Okay, here is the anterior pituitary. Okay. Now, see, from the hypothalamus, now let me show you. This is one, okay, let me show you in the red color. This is a somatotrope. Normally what it will produce? It will produce the growth hormone. Okay, it will produce the growth hormone. There is one more cell called as a lactotrope. What it will produce? It will produce the prolactin. Okay, what it will produce? The prolactin. Now, MCQ for your exam, especially from pharma point of view, okay, they will integrate this. What they will ask you is, there is a nucleus here in the hypothalamus. There is this nucleus. Do you know what this nucleus is producing? Sir, this nucleus is producing a substance called as prolactin inhibitory hormone, also called as dopamine. Okay, dopamine. Do you know what this dopamine will do? Sir, dopamine will always inhibit the lactotropes. Now, in a 10-year-old girl, 15-year-old girl, 20-year-old girl, she's having hypothalamus, pituitary gland is there, she's having a breast tissue, but why she's not lactating? Why she is not producing the milk? Because her hypothalamus is producing the her hypothalamus is producing the dopamine or prolactin inhibitory hormone. This prolactin inhibitory hormone inhibits the lactotropes so that prolactin is not produced before delivering the baby. So without baby, there is no prolactin. Okay, so there is inhibition. This is called as a inhibitory control. One inhibition, and not only that, there is one more hypothalamic nuclei. This hypothalamic nuclei produces something called as somatostatin. Somatostatin. Do you know what this somatostatin will do? Somatostatin will also inhibit the somatotropes. So when the somatotropes are inhibited, growth hormone production will go down. So again, inhibition only. So the question which was asked in one of the exam is inhibitory control. See, inhibitory control by hypothalamus is shown on which anterior pituitary hormones? Somatostatin inhibits growth hormone. Dopamine or prolactin inhibitory hormone inhibits prolactin. Okay, so completed that. Now after this, what else you should know for your exams? Now, first clinical case number 1. If there is damage to the pituitary sac is damaged. What happens? Because of some road accident or because of some trauma, the pituitary stalk is gone. Yeah. What happens? The pituitary stalk is gone. See, all hormones, growth hormone, thyroid stimulating hormone, follicle stimulating hormone, luteinizing hormone, these are all the anterior pituitary hormones, right? You would have already studied these things. Okay. This is a rapid revision. So all these hormones goes down except like ACTH, everything goes down except prolactin. Prolactin will be increased. The levels of prolactin are increased. Why? Do you know the reason why prolactin is increased? Because I taught you something. See, look here. I taught you normally all the time what happens? Normally the dopamine, see, dopamine is continuously inhibiting the lactotrope. Somatostatin is not continuously coming. Somatostatin will come, but not continuously. Dopamine continuously inhibits the lactotropes. But whenever there is a pituitary stalk damage, now you think logically and tell me, whenever, say, this pituitary stalk here, there is a damage. Now, whenever there is a pituitary stalk damage, now do you think that this prolactin inhibitory hormone or the dopamine, can it come down to the lactotropes? Can it come down and inhibit the lactotropes? No, it cannot. So, now what happened to the lactotropes? Now, lactotropes are very happy. Now, lactotropes are activated. Now, lactotropes, what they will produce? They will produce prolactin. So, one point which I want you to know is, there is pituitary stalk damage. All hormone increases except prolactin. Okay, MCQ completed. Next, there is a condition called as Sheehan syndrome. Okay, there is a condition called as Sheehan syndrome. So, Sheehan syndrome is nothing but, see, there is a female, pregnancy. Now, this pregnant female is getting delivered. Now, delivery happened. During delivery, there is postpartum hemorrhage, too much blood loss, heavy blood loss. Heavy blood loss. Whenever there is a heavy blood loss, do you know what happens? There is vasospasm in the body. Too much vasospasm. All the blood vessels are constricted like this. Now even the blood flow to the pituitary gland is also decreased. So now what happened to the pituitary gland? The entire pituitary gland, not just like anterior or posterior pituitary, entire pituitary gland, the whole pituitary gland is necrosed. So that's why here I am showing in black color. So this is called as Sheehan syndrome. It's a complication. It's a complication of postpartum hemorrhage. Okay, even this will come in the obstetrics. Okay, so whenever the female who delivers the baby, whenever she is having this postpartum hemorrhage, too much heavy blood loss, immediately what happened to the blood vessels? Blood vessels will undergo vasoconstriction. Now, whenever there is vasoconstriction, there is less blood flow to the pituitary gland. There is hypoxic conditions in the pituitary gland. The pituitary gland might undergo necrosis. So this is called as a postpartum necrosis of the pituitary gland. Okay, so postpartum necrosis of the pituitary gland is called as the Sheehan's syndrome. Sheehan syndrome. So what happens in Sheehan syndrome? Every hormone decreases. Why? Because the entire pituitary is dead. No, the whole pituitary is dead. All hormones, growth hormone, thyroid stimulating hormone, FSH, LH, ACTH, and prolactin. Every hormone is going down. Okay, so why we need to know this, sir, is because a case will come. If you imagine that you are a female, imagine yourself, you are a female. You delivered a baby. Now, after delivering the baby, what is the first thing that you will do? You will be going for the breastfeeding or lactation, but now lactation will be possible? No. Pituitary gland is gone. No prolactin, no breastfeeding. So that's a major problem. Okay, so completed. Next step. The next case which I want you to know is, see, if you look here, actually these are your eyeballs, right? These are your eyeballs. Okay. So back to the eyeballs, what is this cranial nerve that's coming out? This is the second cranial nerve, that's the optic nerve. Okay. Now both these optic nerves, they are fusing at this point. This point is called as, this junction point is called as the optic chiasm. That junction, both the optic nerves, they fuse. That's called as the optic chiasm. Now, whenever you are having, see, this is a normal location of the pituitary gland. Okay, let me show in red color. This is the place where normally pituitary gland locates. But now, whenever there is a tumor to the pituitary gland, prolactinoma, maybe a tumor called as prolactinoma, tumor of lactotropes. That's the most common thing, most common tumors. Most common pituitary tumors are prolactinomas. Now, your pituitary gland is increasing in size, like this, something like that. Now, whenever there is a prolactinoma, tell me which structure is going to be affected? Sir, now optic chiasm, look here. Because of this prolactinoma, optic chiasm is getting compressed. What happens if optic chiasm is getting compressed? Definitely there will be some visual abnormality. Now, in central nervous system physiology, I will try to explain it better. But here now, whenever there is any damage to optic chiasm because of this prolactinomas or anterior pituitary tumors, now both the eyes, the temporal vision, the side vision, this is the nasal vision, okay. But the side vision called as a temporal vision, that will be lost. This is called as a bitemporal hemianopsia. Okay, this bitemporal hemianopsia is due to damage to optic chiasm. That's the one point which I want you to know. So prolactinomas, which are the most common anterior pituitary tumors, they compress the optic chiasm, leading to bitemporal. Okay. Now, one more thing which I want you to know is, if you are having, for example, a prolactinoma. Now imagine you are a patient, you are having the prolactinoma. Now this prolactinoma, what it will do, it will continuously produce a prolactin. Because of this prolactin, what might happen in the patient? Because of this prolactin, there will be gynecomastia, breast development in the males. Because of this prolactin, a female, a just 15 years old female, now she will start to lactate because of this prolactin, unnecessary prolactin. Now she will start to lactate, and it's called as galactoria. And because of this prolactin, normally see, prolactin inhibits the menses. This is the thing which you should know from your gynecology. Till the time prolactin is there in the body, prolactin inhibits the menses, inhibits the reproductive cycles. So in prolactinoma, there is amenorrhea, no menses is going to be there. So whenever the patient is getting this prolactinoma, what kind of problems he or she is going to get? Bitemporal hemianopsia is going to be there, and there will be headaches will be there because of that tumor. No, headaches will be there. Bitemporal hemianopsia will be there. Lactational amenorrhea will be there, and galactoria and gynecomastia will be there. Okay, these are the problems. And in the recent FMGE exam also, this question has been tested many times. Now, prolactin, like imagine I'm the person who is having prolactinoma. I'm having a prolactinoma. Now, too much prolactin is getting produced in my body. If I come to you, how you should treat me? You have to decrease the prolactin levels in my body. As a medical management, you have to decrease the prolactin levels in my body. Who is the antagonistic of prolactin? The antagonistic of the prolactin is dopamine. So dopamine-like drugs are used. So drugs which will decrease the prolactin levels, are dopamine-like drugs, are dopamine agonists, like cabergoline and bromocriptine. At least I want you to know these things. Cabergoline is a drug of choice, okay, for all the prolactin related problems. So cabergoline and bromocriptine, these are dopamine agonists which will decrease the prolactin levels in the blood. Okay, so completed. After this, what else you should know? Now, for your FMG exam, I will tell you the one thing: posterior pituitary. Posterior pituitary, it will produce which hormones? Come on, tell me. Posterior pituitary produces which hormones? So posterior pituitary, it doesn't produce any hormones. First of all, it doesn't produce any hormones. It stores certain hormones. What are they? See, now this is the hypothalamus. No, hypothalamus. Actually, hypothalamus, there are two nuclei. Remember it like this. Many times this mnemonic, I have said this mnemonic many times. There is a nucleus called as a supraoptic nucleus, SON. See, supraoptic nucleus, which was written over there. Don't worry. See, this supraoptic nucleus, SON, it produces a hormone called as antidiuretic hormone, ADH, antidiuretic hormone. And there is a nucleus called as a paraventricular nucleus, PVN. Paraventricular nucleus produces the oxytocin. Okay, see paraventricular nucleus, what it is producing? Paraventricular nucleus, it produces the oxytocin, and supraoptic nucleus, it produces the antidiuretic hormone. So these hormones are produced in where? The hormones are produced in the hypothalamus. But where they are stored? They are stored in the posterior pituitary. They will come and they are getting stored in the posterior pituitary. That's it. Okay. So the same thing. The posterior pituitary does not produce any hormones. It stores hormones, oxytocin and ADH. Okay, and don't never ever confuse. Don't say something like this SOAP. If you write like this and say supraoptic nucleus produces the oxytocin, blunder. No. Supraoptic nucleus, what it will do? Supraoptic nucleus produces the antidiuretic hormone. Paraventricular nucleus produces the oxytocin. Okay. Now, the questions which you need to know is, sir, oxytocin. What are the functions of the oxytocin? Many times, at least minimum of 10 times this question has been asked. What oxytocin will do? Oxytocin causes uterine contractions during delivery. Causes the uterus to contract, causes the delivery. Simple. What else? This oxytocin after the delivery, this oxytocin acts on the breast tissue, causes the milk let out. Okay, like it will cause the milk to come out of the breast. So that's the galactokinesis. Okay, galactokinesis or milk ejection. Remember, galactopoiesis is different. Galactopoiesis is because of prolactin. Okay, let me write here. Prolactin causes milk production, but oxytocin causes milk ejection. Oxytocin milk ejection, okay. Oxytocin also causes milk ejection or galactokinesis. Both are same. Milk ejection or galactokinesis. Milk production or galactopoiesis. They are one and the same. Okay. Next. What else I want you to know? Points which I want you to know is, question was asked. Okay, oxytocin. Okay. Now, vasopressin. See, this vasopressin is also called as what? Antidiuretic hormone. Vasopressin also called as antidiuretic hormone. Okay. Now, this vasopressin, yes, it is produced by the supraoptic nucleus. Already I have discussed. This vasopressin is stored inside certain bodies. Vasopressin is stored inside herring bodies. So, vasopressin is stored in herring bodies. Herring bodies, these are the vesicles. The vesicles in which the vasopressin molecules are stored. Antidiuretic hormone molecules are stored. Now, important MCQ which I want you to know is, sir, this ADH, antidiuretic hormone, it have how many types of receptors? Oxytocin completed. Forget about it. ADH have 3 types of receptors. What are they? V1, V2. Okay, V1, V2 and V3. V1, V2 and V3. V3 is also called as V1B. So, V1 receptors, V2 receptors and V3 receptors. If this antidiuretic hormone, if this ADH, if it acts on V1 receptors, do you know what happens? First of all, where these V1 receptors are present? So the V1 receptors, they are present on the blood vessels. V1 receptors are present on the blood vessels. If you stimulate the V1 receptors, there is vasoconstriction MCQ. That's it. Done. V1 receptors are present on the blood vessels. V1 receptors will cause vasoconstriction. That's why the name vasopressin. V2 receptors, where they are present? V2 receptors are present in the nephrons, collecting ducts. So V2 receptor, when you stimulate the V2 receptors on the collecting ducts, nephrons, now what happens? Water reabsorption. Okay, I will explain this in detail in the renal physiology, but for now, in detail in the sense, I will explain this topic there also. The V2 receptors are present in the collecting ducts of the nephrons, helps in the reabsorption of the water. V1 receptors are present on the blood vessels, helps in the vasoconstriction. V3 receptors are present on the anterior pituitary. Okay, V3 receptors are present on the anterior pituitary. They helps in secretion of the ACTH, adrenocorticotropic hormone, ACTH. Completed. So V1 receptors on the blood vessel, V2 receptors on the collecting ducts, and V3 receptors on the anterior pituitary. V3 receptor activation, V3 receptor stimulation will cause the release of ACTH. V2 receptor stimulation will cause water reabsorption. V1 receptor stimulation will cause vasoconstriction. That's why the name vasopressin. Okay, enough. Now after this, what you should know regarding the growth hormone. Okay, regarding growth hormone, you know many things, but my questions here. Growth hormone, it's an anabolic hormone. Okay, growth hormone, it's an anabolic hormone. Anabolic hormone. So one important point about the growth hormone is growth hormone increases the blood glucose levels. I want you to know this. Okay, growth hormone, what it will do, sir? It will increases the blood glucose levels. Okay, so that's why if the patient is having growth hormone deficiency, the patient is going to suffer with hypoglycemia. Okay, during, imagine that I am a child. Okay, imagine that there is this one child who is having no growth hormone, deficiency of the growth hormone. So what he is going to suffer with? So during childhood, if the growth hormone deficiency is there, the patient is not able to grow. He won't grow. That will cause dwarfism. So this dwarf people, the point which I want you to know is this dwarf people are going to have hypoglycemia. That's the one important thing. This dwarf people are going to suffer with hypoglycemia, sir. Done. Now, if you're having growth hormone excess, now imagine I am a child. Imagine I'm a child. Maybe I'm 10 years. Now I'm having too much amount of growth hormone. See, growth hormone excess, too much amount of growth hormone. During childhood, before the closure of epiphysis, now that will cause a gigantism. Okay, you know this already, you know this. The patient is going to be tall. He's going to be a giant. But my questions here mainly is, what happens if there is excessive growth hormone right now after the closure of the epiphysis? I'm not a child. I'm not in my adolescent stage. I'm not in my puberty. Now I'm an adult. Now, if you inject growth hormone into my body, too much amount of growth hormone into my body, do you think that I will grow? No, I'm not going to grow. So, after the closure of epiphysis, that's going to cause too much amount of growth hormone. Growth hormone excess is going to cause a condition called as acromegaly. Acromegaly. Okay, acromegaly. Now, this was the question, image-based question. So, this patient, if you inject too much amount of growth hormone into my body, so what are the clinical features? Now, because of this growth hormone, growth will happen. Not a linear growth. Now, organ size will increase. The thickness of the bones will increase. So now you can see frontal bossing will be there. There will be protrusion of the jaw. Prognathism is going to be there. The tongue size increases and it will fall out. Like just like a dog, for a dog, how the tongue is will be there hanging. So there will be frontal bossing, increase hand and foot size. The thickness of the bones is getting increased. Large, fleshy, beefy tongue can be there. Prognathism can be there. Because of hyperglycemia, more growth hormone, more blood glucose levels, that can even lead to diabetes mellitus followed by coronary heart diseases. Okay, the size of the heart increases, cardiomyopathies, all these things will be there. But I don't want to go in all this in detail. Simple. Frontal bossing, if whenever you see such a kind of image-based question with a frontal bossing, prognathism and large beefy tongue, that is acromegaly. Acromegaly. The question which I want you to know is the treatment. This is the MCQ. Treatment. How to treat? How to treat this acromegaly? How to treat is, you can use a drug called as somatostatin analog. You know, somatostatin decreases the growth hormone. Somatostatins decreases the growth hormone. So somatostatin analogs like octreotide and lanreotide. So octreotide and lanreotide, these are the drugs which are used in the treatment of acromegaly. True. And growth hormone receptor, let's block the growth hormone receptor. Okay, let the growth hormone be there. Let it be there. Growth hormone, too much amount of growth hormone is okay, let it be there. You can block what? You can block the receptors of growth hormone. This is the MCQ. So growth hormone receptor blocker is called as a pegvisomant, and it can be also used in the treatment of acromegaly. MCQ done. Okay, so the treatment of acromegaly, I want you to know at least these two things. So somatostatin receptor analogs like octreotide and lanreotide, or you can block the growth hormone receptors. The growth hormone receptor blockers include pegvisomant. That's completed. So if you know this, that's more than enough. Now after this, now what else I want you to know? There are so many things, but see, growth hormone, the next important point I want you to know is growth hormone. It will go to the liver, sir. The growth hormone will go to the liver. In the liver, the growth hormone, these are the growth hormone receptors. When the growth hormone is acting on the growth hormone receptors, now liver is going to produce a substance called as insulin-like growth factor, ILGF-1. So insulin-like growth factor is produced by the liver under the influence of this growth hormone. Growth hormone, when it acts on the liver, liver produces insulin-like growth factor. It also promotes the growth. This is the one point I want you to know. Okay, so insulin-like growth factor production is produced by growth hormone only. Next, what else you should know? In the endocrine physiology, say thyroid hormones. In the thyroid topic, point which I want you to know is how thyroid hormones are produced. What are the steps in the production of the thyroid hormones? What are the steps in the production of the thyroid hormones? Okay, that's the MCQ. See, the steps here, the main important steps I am talking about. So the main important steps, main. There is an enzyme called as thyroid peroxidase. Okay, this is the thyroid gland. Inside the thyroid gland, I'm showing you. This is the thyroid gland. Inside the thyroid gland, these are the cells. The cell's name is called as the follicular cells. Inside the thyroid gland, there are follicular cells present. In this follicular cells, there is an enzyme present called as thyroid peroxidase. This one single thyroid peroxidase, do you know what it will do? It will do three reactions. Three reactions, what are they? Oxidation, organification, and coupling reaction. So, MCQ that will come in your exam is oxidation, organification, and coupling reaction are done by which enzyme? So, all the three, oxidation, organification, coupling reaction, all these three reactions in the thyroid hormone biosynthesis are under the control of an enzyme called as thyroid peroxidase or TPO. Okay, done, sir. What you need to know for your exam, especially to treat hyperthyroidism. Hyperthyroidism means more thyroid hormone is there. How can you treat hyperthyroidism? How can you decrease the T3 T4 hormone production? Means, say, by inhibiting this thyroid peroxidase. How to inhibit this thyroid peroxidase? Thyroid peroxidase is inhibited by propyl thiouracil, PTU, MCQ, propyl thiouracil, methimazole, and carbimazole. These drugs. So, propyl thiouracil, methimazole, and carbimazole, these are anti-thyroid drugs. What they will do? They will inhibit thyroid peroxidase. So, oxidation, organification, coupling reaction are inhibited. When they are inhibited, no T3 T4 production, no T3 T4 production. Now, here, one more thing which I want to put into your mind is, say, this follicular cell. Do you know what is the first step? Okay, regarding the TPO, oxidation, organification, coupling reaction, I have discussed. For the production of T3 T4, you need to have oxidation, organification, coupling reaction. Okay, but this question was asked in the NEET PG exam. This question was asked in the NEET PG exam. It might come in the FMGE exam also. Anytime. First, you need to uptake. This is the blood, right? This is the blood. You have taken a seafood, for example. After the class, you went and ate seafood. For example, you fish. Now, seafoods are rich in what? They are rich in iodides. Okay, iodides. Now, first of all, you have taken this seafood, it's digested, and you have got the iodides into your body, and the iodides are absorbed. And where these iodides are now, they came into the blood. Now see these iodides, now they are going into the thyroid gland. The thyroid gland will take the iodides. What is the name of this transporter? MCQ. There is this transporter on the follicular cells called as sodium iodide symporter. So with the help of the sodium iodide symporter, okay, with the help of the sodium iodide symporter, the iodides will be absorbed. Iodides are absorbed with the help of sodium iodide symporter. That's MCQ. Okay. So tell me, sodium iodide symporters are present where? The sodium iodide symporters are present on the follicular cells. But see here, there are other places where the sodium iodide symporters are present. I'm not going to explain you. Just you need to by heart this. So this is the exact question which was asked. Sodium iodide symporters are present on which cells? Except kind of questions will come. So see, the sodium iodide symporters are present on the follicular cells or the thyrocytes. Yes, they are present on the thyrocytes. But not only the thyrocytes, salivary glands, gastric mucosa, placenta, okay, choroid plexus, mammary glands, all these places also you will have the sodium iodide symporters. Remember, CQ. Now, after this, what else you should know? Guys, answer my question. Answer my question. How many types of thyroid hormones do you know? Two hormones, sir. T4 and T3. T4 and T3. Who is produced in maximum quantity? T4, sir. Maximum quantity, T4. Max. T4 is max. T4 will be converted into T3. And this T3, it is the active form. This T3 is the active. Okay, this is the real one. Okay, this is the real one. T3 is the real one. T4 and T3. Wherever it is needed in the body, okay, wherever and whenever it is needed in the body, the T4 will be converted into T3 in the tissues. So this is the MCQ. So T4 will be converted into the tissue. T4 will be converted into the T3 in the tissues with the help of an enzyme called as 5' deiodinase. With the help of an enzyme called as 5' deiodinase, which is present in the tissues, which will convert the T4 into the T3 active form. MCQ is, who will inhibit this 5' deiodinase? Which drugs inhibit this 5' deiodinase? There are certain anti-thyroid drugs which are used in the treatment of hyperthyroidism. Imagine if I am suffering with hyperthyroidism, you can use a drug called as propyl thiouracil. Yes. So propyl thiouracil, here I have discussed the PTU. See, where is that? See, propyl thiouracil It not only inhibits the thyroid peroxidase enzyme, it not only inhibits oxidation organification coupling, but the propyl thiouracil, this drug, this PTU, also inhibits this process called as peripheral conversion. So this process which I am showing you, T4 to T3, this process is called as a peripheral conversion, which is happening at the level of tissues with the help of an enzyme called as 5' deiodinase. This 5' deiodinase, this enzyme, it is inhibited with the help of a drug called as propyl thiouracil. So now tell me, propyl thiouracil, yes, it inhibits thyroid peroxidase, true. It also inhibits peripheral conversion, true. Both are true statements. Okay. Now, apart from this, what else I want you to know? Not only propyl thiouracil inhibits the 5' deiodinase. Yes, it inhibits the 5' deiodinase, but not only propyl thiouracil, but also drug called as propranolol. Okay, so propranolol, again starting with the letter PC. So P, propranolol and propyl thiouracil. Propranolol and propyl thiouracil, P for P. These two drugs, they will inhibit what? They will inhibit peripheral conversion. So propyl thiouracil and propranolol are the drugs which will inhibit the enzyme called as 5' deiodinase. They inhibit the peripheral conversion. Okay, they will inhibit the peripheral conversion. So done. After this, what else I should teach you? Now, the points which I want you to teach you is like, all the effects of the thyroid hormones. These are like, these are the basic things which you which you have studied in regular classes also. Okay, they are not that important. Now, concentrate. Point which I want you to know is thyroid hormones. Okay, T3 mainly, it increases the basal metabolic rate. Okay, T3 increases the basal metabolic rate. How? Basal metabolic rate means how many calories are required in a day to maintain the homeostasis, to maintain all the reactions in the body, to maintain all the biochemical reactions, to keep this body alive for the next 24 hours. How many calories are needed? I will say I need almost 3000 kilocalories. Okay, I need almost 3000 kilocalories to maintain all the homeostasis in the body. That's my basal metabolic rate. If you ask a girl, if she is not doing, for example, active work, then 2500 kilocalories are enough. Usually, when compared to a male, females will use less calories because their body weight is less. Males will be doing harder work, so more BMR. My question to you is here, the thyroid hormones, yes, it increases the basal metabolic rate. So how? How means, remember, this is a very important MCQ. This is your body cell. Okay, this is your body cell. Now, this is the T3 hormone. Now, the T3 hormone, say, do you know what it will do? Before telling what it will do, look here. On this body cell, there is a universal transporter present. Universal transporter. It is taking it is taking 2 potassium ions into the cell and throwing out 3 sodium ions out of the cell. 2 potassium is coming into the cell, 3 potassium is going out of the cell with the help of ATP. ATP will be broken down. 2 potassium comes into the cell, 3 sodium goes out of the cell. This is called as sodium potassium ATPase. This is called as the sodium potassium ATPase. This channel is called as the sodium potassium ATPase. On this cell, tell me how many sodium potassium ATPase are there? 1 sodium potassium ATPase. For example, 1 sodium potassium ATPase. Now, if I inject myself, for example, I am taking this thyroid drug, I am taking this thyroid levothyroxine tablet. If I take too much amount of this thyroid hormones, do you know what these thyroid hormones will do? Thyroid hormones directly cross the cell membrane, remember. Thyroid hormones directly enters into the nucleus. Okay, thyroid hormone have the receptor where thyroid hormone receptor is present in the nucleus. So that's the MCQ. So thyroid hormones have intranuclear receptor. Thyroid hormones have intranuclear receptors. Now, when the intranuclear receptors are activated, now they are going to activate the genes. They are going to do the transcription. So certain genes are activated, transcription will happen at the end of the day. See, now what is happening on the cell? When the thyroid hormones are acting on the cell, please tell me what happened to the number of sodium potassium ATPases. So the sodium potassium ATPases on the cell are increasing. See, the number of sodium potassium ATPases are increasing. Okay. So sodium will come out, 3 sodium is coming out, potassium is coming in. Sodium will go out, potassium will come in. So the number of sodium potassium ATPases are increasing.
So now tell me, more ATP are getting broken down or less ATP are getting broken down? So the more ATP is getting broken down. Okay, so when the more and more ATP are getting broken down, see, more calories are utilized or less calories are utilized? More calories are utilized, more ATP are being broken down. So that's how. So thyroid hormones, yes, they increases the BMR, they increases the calorie usage. How? By increasing sodium, potassium, ATPases on tissues. This is the MCQ. This is the MCQ. Look here. So throughout the body and tissues, what it is doing? So increases the basal metabolic rate. How thyroid hormones increase the basal metabolic rate? By increasing number of sodium, potassium, ATPases. NEET PG MCQ. This was the NEET PG MCQ. Thyroid hormones increases the basal metabolic rate in all the tissues, except if I take a thyroid hormone, my basal metabolic rate is going to be increased everywhere, except these are the exceptions. Exceptions include the testis, uterus, lymph nodes, spleen, and anterior pituitary. In these 5 places, except these 5 places, uterus, testis, lymph nodes, anterior pituitary, and spleen, except these 5 places, everywhere the basal metabolic rate is going to be increased. This is one point. Okay, done. And thyroid hormones, remember, more and more ATP are getting broken down. Under the influence of the thyroid hormones, more and more ATP are getting broken down. So more calories are being broken down. More heat will be produced in the body. So thyroid hormones, that's why thyroid hormones are called as thermogenic hormones. They are the thermogenic hormones, means they increases the body temperature. They are the thermogenic hormones. They increases the basal body temperature. Okay, this is the point which I want you to know. Enough. If you know this, that's more than enough. Okay, guys, is it clear? Regarding the thyroid hormones, is it clear, guys? Are you clear with the thyroid hormones? So don't worry about the notes. PDF will be shared in the group. Don't worry about that. Oh, like some guy is watching from Afghanistan. Yes. Excellent. Great. Excellent. Like some guy is saying, higher the afterload, higher the propensity to develop the cardiomyopathies, especially hypertrophic cardiomyopathies. Excellent. Excellent. That's a true statement. If you're having aortic stenosis, imagine aortic stenosis. Yes, afterload will be more. Whenever there is aortic stenosis, the afterload is more. The left ventricle is trying more harder to push the blood into the aorta. Yes, hypertrophic cardiomyopathy can happen. Yes, true. Absolutely. Excellent mid content. You are true. You are true. So now after this, thyroid hormones, like thyroid hormones, catabolic hormones, yes, I have discussed. Next, what you should know. All the general regular activities of the thyroid hormones, you know it. But for exam point of view, I'm telling you, though this is not a pathology session, but say, you know about hyperthyroidism, hypothyroidism, right? I'm asking you generally, mixed edema is seen in hyper or hypothyroidism? Hyper or hypothyroidism? Can you tell me? Mixed edema. See, mixed edema is a feature of hyper or hypothyroidism. Mixed edema is a feature of. Watching from China. Great, Gagan. Mixed edema, it's a feature of both hyper as well as hypo. Both the hyper and hypothyroidism patients can have mixed edema. In both the patients, yes, you can have mixed edema. But highly, like, this question can come in your exams, like, highly likely, okay? See, if they use this word pretibial mixed edema, then the answer is Graves' disease. Okay, sir, there is a disease called as Graves' disease, which will cause hyperthyroidism. Okay, there is a disease called as Graves' disease, which will cause a hyperthyroidism. Okay, so in this Graves' disease, they will definitely use this word pretibial mixed edema. So pretibial mixed edema means 100% Graves' disease, hyperthyroidism. But if they simply say if they simply use the word mixed edema, yeah, mixed edema can be seen both in hyper as well as hypothyroidism, more commonly in the hypothyroidism, But pre-tibial mixed edema, answer is Graves' disease. That's it. Now, after this, let's talk about the pancreas and the pancreas related things. Pancreas, yeah, it's a mixocrine gland. It produces both the, it have both the functions, exocrine functions as well as, typing mistake, endocrine. Okay, it produces both exocrine as well as endocrine functions are there. Now, from your basic biochemistry classes, I am not going in detail. You have studied alpha cells of the pancreas produces the glucagon, beta cells produces the insulin, delta cells or the D cells produces somatostatin. So yes, somatostatin is produced from the hypothalamus. True, the somatostatin is also produced from the pancreas. The D cells or the delta cells produces the somatostatin. True. F cells of the pancreas produces the pancreatic polypeptide. All these are the hormones. And epsilon cells or E cells produces the ghrelin. Super MCQ which you need to know for your exam is a ghrelin. When ghrelin is produced? Ghrelin is produced during fasting. During fasting states, this ghrelin is going to be produced from the pancreatic epsilon cells. And what is the function of this ghrelin? Hunger. When you are doing fasting, you will have the feeling of hunger, right? Why? Because of this ghrelin only. So this ghrelin, yes, it increases the hunger, the feeling of hunger. And not only that, remember, ghrelin increases the growth hormone production. FMGE MCQ. Ghrelin increases the growth hormone production. Why growth hormone? Why? Because growth hormone increases the blood glucose levels during fasting. That's why. Okay, so during fasting, ghrelin is produced. Ghrelin stimulates the release of the growth hormone. Growth hormone increases the blood glucose levels. That will be helping for you during the fasting. Okay, so done. Now, look here. Please concentrate here. This beta cells, what they are producing? They are producing insulin. So not only insulin, what they are producing amylin also, as well as C peptide. This C peptide is repeatedly asked MCQ. Okay, see now. Imagine this is a beta cell. This is a beta cell of the pancreas. Now this beta cell of the pancreas, it is producing what? It is producing insulin. Now, not only insulin, the same beta cell of the pancreas, it also produces a molecule called a C-peptide. C-peptide. If 100 molecules of insulin are produced, it means 100 molecules of C-peptide is produced. If 1000 molecules of insulin is produced, it means 1000 molecules of C-peptide is produced. See, this is C-peptide. It comes out in the urine. It comes out in the urine. So now, imagine there is this urinary sample. I'm doing the urine analysis. Okay, I'm doing the urine analysis. Now, if there are 1000 molecules of C-peptide in the urine, I can estimate by looking at the urinary C-peptide levels, I can estimate how much insulin is produced in the body, how much endogenous insulin is produced in the body, right? So that's why this is the MCQ. The C-peptide, it is produced in equimolar concentration along with insulin. Along with insulin, C-peptide is produced in equal concentration. So it is considered as endogenous marker of insulin. It's considered as an endogenous marker of the insulin. That's it. MCQ completed. Okay. Now insulin. Some important points. Insulin is a peptide hormone. Okay. But now imagine this is the beta cell. This is the beta cell. Now this beta cell, it contains the vesicles. Now inside this vesicles, who is there? Insulin molecule. So insulin, here is the insulin. Now MCQ which I want you to know is the insulin is stored along with which ions? Sir, insulin molecules are stored along with zinc ions. Why? Because this zinc stabilizes the structure of insulin. Okay, zinc stabilizes the structure of insulin. That's why insulin is stored along with zinc ions. For your FMGE, this question is important. Deficiency of the zinc will cause a disease. This was FMGE MCQ. Deficiency of zinc will cause a disease called as anyone? Anyone, can you tell me? Deficiency of zinc will cause which disease, sir? Come on, Gagan, Naimat, Talib. Mid content, can you tell me? Deficiency of zinc is going to cause a disease called as, it starts with the letter A. Acrodermatitis, enteropathica. Okay, so acrodermatitis enteropathica is a disease due to deficiency of zinc. Like, you should answer, man. Like, it's very important for FMG. Okay, so insulin is stored along with zinc ions. And generally, I am speaking, generally from the nutrition point of view, zinc deficiency will cause a disease called as ectodermatitis enteropathica. Okay. Now, next, see, in this image, I'm showing you this is a beta cell. Okay, this is a beta cell. Now, this beta cell, it is releasing the insulin at the end of the day. See, these are the secretory granules. These are the secretory vesicles which contains the insulin. Okay, here insulin is there. Question which I want you to know is, why insulin is getting released? How insulin is getting released? Okay, to release insulin, what you should do, what one must do. I'm not going in detail. Okay, simple. On this cell, see, on this beta cell, look at this channel. This green color channel. Do you know what is the name of this channel? This is called as ATP sensitive potassium channel. Okay, ATP sensitive potassium channel. Now, what this ATP sensitive potassium channel is doing all the time, 24/7, it is causing potassium efflux. Potassium is going out of the cell. Okay, potassium is going out of the cell. Okay, so positive charges are going out of the cell. So cell is resting. Cell is inactive. But let me tell you what happens. You eat biryani. Okay, you have taken the biryani, or the heavy meal. You have taken the heavy meal. The food is going to be digested. Now, when the food is digested, what happens? The blood glucose levels rises. Now, blood glucose level is rising, sir. Now, is it good to have high levels of glucose in the blood? No. So, whenever the blood glucose level is raised, which hormone do we need? Insulin. We need the insulin. Whenever the blood glucose levels are more, we need the insulin. So, see, whenever the blood glucose levels are more, see this glucose. Now, first it will enter where? First it will enter into the beta cells. Now, this glucose, it is entering into the beta cells. See. Okay. Glucose is entering into the beta cells. Now, do you know what is glucose will do? Glucose, it will participate in the glycolysis, electron transport chain, Krebs cycle, completed. First glycolysis, Krebs cycle, electron transport chain. At the end of the day, ATP is produced. So, you ate food, glucose is released, glucose is more there in the blood. Okay, glucose is more there in the blood. This glucose enters into the pancreatic beta cells. This glucose, at the end of the day, produces the ATP. Now, glucose produces the ATP. Now, do you know what this ATP will do? ATP will go and close this channel. So, that's why this channel is called as ATP sensitive potassium channel. So, these potassium channels are blocked because of ATP, under the influence of the ATP. So, that's why these are called as ATP sensitive potassium channels. Now, tell me what happens. Sir, potassium is getting accumulated inside the cell. The positive charges are being accumulated inside the cell. Now, these positive charges activating the cell, depolarizing the cell membrane. Okay, so now whenever the cell is being activated, now say because of this depolarization, now first calcium will come into the cell. Remember MCQ, general physiology MCQ. So first, because of the depolarization, first calcium comes into the cell via this channel, via the voltage gated calcium channel. Calcium will come into the cell. This calcium, it helps in vesicular transport. Calcium helps in what? Calcium helps in the vesicular transport. So this vesicles which contains the insulin is released into the blood. This is how insulin is released. Okay. So now tell me MCQs. ATP sensitive potassium channels are present on beta cells of the pancreas. Okay. So depolarization, this one. Activation of this beta cell. Depolarization of this beta cell of the pancreas is dependent on which ions? It is dependent on potassium. Okay. It's dependent on the potassium ions. Now, glucose enters into this beta cell. Glucose enters into this beta cell via which channels? Via glucose transporter type 2. Many times this question has been asked. After the taking of the food, there is a glucose spike in the blood. This glucose will enter into the beta cells of the pancreas by using which channels? GLUT2 or glucose transporter type 2. So glucose transporter type 2 is present on the beta cells of the pancreas. True statement. This glucose helps in the production of ATP. ATP goes and closes the ATP sensitive potassium channels, leading to the depolarization, leading to the calcium influx. Calcium helps in exocytosis or vesicular transport of the insulin. Insulin is released. Okay, insulin is released. Now you can ask me, sir, what this insulin will do? Mechanism of action of insulin. Only one important MCQ. See, this insulin, this is the insulin molecule. Okay, this is the insulin molecule. Do you know where insulin will act? Sir, insulin, it is acting on which tissues? Skeletal muscles as well as adipocytes. This is the MCQs, very, very important MCQs. Insulin acts on skeletal muscles and adipocytes. Very, very important MCQs. Insulin is not acting on the RBC. Insulin is not acting on the blood cells. Insulin is not acting on the, the central nervous system. No. Insulin is acting on which cells? Skeletal muscles, adipocytes. Do you know what this insulin will do? Sir, insulin molecules at the end of the day, I'm not going in detail. Because of this insulin, see, now you are having these transporters. Previously, they are not there. Previously, these transporters are not there. Now, insulin helps in production of these transporters through which the glucose will be absorbed into the adipocytes. Previously, the adipocytes and skeletal muscles, previously, they are not uptaking any glucose molecules. For example, imagine, this is my skeletal muscle. Now, whenever the insulin is acting on my skeletal muscles, now this is skeletal muscles. They will produce which transporters? Glucose transporters type 4. With the help of these glucose transporters, now from the blood, the glucose will be absorbed into the skeletal muscle. So what happened to the blood levels of glucose? Comes down. That's it. Okay. So tell me, the glucose transporters type 4 are present on skeletal muscles and adipocytes. And who helps the production of glucose transporters type 4? Insulin. Completed. Okay. Now, after this, what else I should teach you? Other actions of insulin, especially this is integration. This is an integration with the biochemistry. Very, very important. Insulin topic is very important. Alright, guys, please tell me, what is the function of insulin? Tell me. Sir, at the end of the day, insulin have to decrease the blood glucose levels. So, do you know what this insulin will do? Sir, insulin will activate those biochemical reactions. See, these are the biochemical reactions. They will decrease the blood glucose levels. See, if these biochemical reactions, if these biochemical reactions like glycogenesis, lipogenesis, glycolysis, what they will do, all these reactions, they will decrease the blood glucose levels. Okay. So, what insulin is doing is, insulin is stimulating this biochemical reaction. So, they will ask you, which of the following is a function of insulin except kind of questions. All of the following are the functions of insulin except kind of questions. Okay. So, insulin stimulates glycogenesis, lipogenesis, glycolysis. They are all activated. Because of this, the insulin levels, glucose levels decreases. In the same way, insulin, they will inhibit these biochemical reactions. See, these biochemical reactions, they are associated with increasing the blood glucose levels. See, for example, glycogenolysis, the glycogen broken down. When the glycogen is broken down, glucose molecules are released from the liver. Blood glucose levels are increased. That's not needed now whenever the insulin is there. So what insulin is doing? Insulin inhibits glycogenolysis. Gluconeogenesis means glucose neosynthesis, right? And lipolysis and ketogenesis. So these things are inhibited. So the reactions which are inhibited by insulin, the reactions which are stimulated by insulin, very important for your exam. Done, sir. Any other functions of the insulin which you should know for your exam? Yes. Insulin and relation with the potassium ions. When I inject insulin into my body, for example, when I take an insulin shot, do you know what insulin will do? Yes, it causes the movement of glucose from the blood into the tissues. But not only that, sir, this insulin, it moves the potassium ions. This is the first action. This is the first action of the insulin actually. The potassium ions, all the potassium which is present in the extracellular space, it will go into the cell. Potassium moves into the cell. So insulin moves potassium ions into the cells. Yes. So because of this action, actually insulin can be used in the treatment of hyperkalemia. So if I'm having hyperkalemia, more potassium, just give insulin. All potassium will go in packed inside the cell. The insulin moves the potassium into the cells. Done. Okay. Completed, guys. So these are the point which I want you to know. And many students don't know this actually. They will know only this thing. Insulin decrease the blood glucose levels. Yes, insulin decrease the blood glucose levels and glucagon increase the blood glucose levels. But remember, not only glucagon increase the blood glucose levels, I said you, thyroid hormones, general classes also, many YouTube sessions I have taught you this. Glucagon, growth hormone, thyroid hormones, cortisol, catecholamines, all these are hyperglycemic hormones. All these are the hyperglycemic hormones. All of them, they will increase the blood glucose levels. But who will decrease the blood glucose levels? Insulin. Insulin decrease the blood glucose levels, but all other hormones increase the blood glucose levels. Okay. Now, this is also completed. Now, after this, what I should teach you? Uh, Now, the MCQs which I want you to know is the last FMG exam. Then just last, the 6 months back, whatever the FMG exam happened, this was the question asked. Whenever there is no insulin in your body, see, here I have taught you something. Look at this. Insulin, what it is doing to the ketogenesis, it will prevent. Insulin prevents the ketogenesis. So till that time, I am a healthy individual. Okay. Now, till the time I am having insulin in my body, the ketogenesis does not occur. Okay, ketone body formation is not happening. Ketone bodies, they are energy rich substances. Just like glucose, they are also energy rich substances, but they are having their own, negatives. They are the acids. They will cause acidosis. But remember, till the time insulin is there in my body, no problem. Ketone bodies are not produced. But see, whenever you are suffering with insulin deficiency, you know about the diabetes, right? Diabetes, type 1 diabetes mellitus, insulin is not there. Okay, in type 1 diabetes mellitus, the beta cells in the pancreas, they are gone, they are damaged, autoimmune damage to beta cells. Autoimmune damage, beta cells gone. So there is no insulin. Now see here, whenever there is no insulin, what will happen? What happened to the blood glucose levels? Blood glucose levels are so much elevated. Okay, so whenever there is no insulin, see, what happened to the glycogenolysis? Glycogenolysis is activated because I have taught you normally insulin will inhibit the glycogenolysis, glyconeogenesis. It's inhibiting. But whenever insulin is not there, glycogenolysis is activated, gluconeogenesis is activated. Okay, so look here. So whenever there is no insulin deficiency, glycogenolysis, gluconeogenesis. So because of that, what happened to the blood glucose levels? Blood glucose levels are super high now. So much blood glucose levels are there. Now tell me, whenever there is more glucose in your blood, more glucose is filtered in your kidneys or not? Yes, more glucose is filtered in your kidneys. All this glucose cannot be reabsorbed. So all this extra glucose will come out in the urine. Wherever glucose goes, water follows. So now if I imagine I'm a diabetic. Okay, there is no insulin is there. So my blood glucose levels are super high. Glucose is getting filtered in my kidneys. Now I cannot reabsorb all this extra super high glucose. So glucose is going out in the urine. Wherever glucose goes, water follows. So more glucose excretion, more water excretion. That's causing diuresis. So the patient now is having osmotic diuresis. Okay, I'm talking about a condition called as a diabetic ketoacidosis. What is happening? I will tell you. Don't worry. Diabetic ketoacidosis, there is severe deficiency of insulin. Whenever there is severe deficiency of insulin, the blood levels of glucose increases. Glucose excretes out of the body. Water also excretes out of the body. Wherever glucose goes, water follows. There is osmotic diuresis leading to excessive urination. In diabetic ketoacidosis, the patient is having excessive urination. The patient is having dehydration because of excessive urination. The patient is having excessive thirst, more and more thirst, polydipsia and polyuria. Okay, so these are the problems with diabetic ketoacidosis. Excessive. See, NEET PG exam, FMG exam, last NEET PG, last FMG exam. In last NEET PG exam, 2 MCQs were there on diabetic ketoacidosis. Last FMG exam, 1 MCQ was there. Okay, so imagine I'm the person who is suffering with the diabetic ketoacidosis. I'm going to suffer with dehydration, polyuria, polydipsia. Okay, not only that, I have said you, whenever insulin is not there, lipolysis will happen and ketogenesis, ketone bodies are produced. Okay, so lipids are getting broken down. From the lipids, by using these fatty acids, ketone bodies are getting produced. So no insulin, ketogenesis, ketone body formation is happening in the body. Okay. So now MCQ is, sir, these ketone bodies are actually good only, but they are having their own negatives. The problem with these ketone bodies like acetone, beta hydroxybutyrate and acetoacetate, the problem with these ketone bodies is these are acids. So they are causing acidosis in the body. Okay, that's why diabetic ketoacidosis. The patient is a diabetic, no insulin. Whenever there is no insulin, ketogenesis is happening. The ketone bodies are acids. That's why diabetic ketoacidosis. Okay, so now let's concentrate on the MCQs. So these ketone bodies are the acids. They are the metabolic acids. So that is causing acidosis, metabolic acidosis. Now, in your respiratory physiology, you would have studied whenever you suffer with acidosis. Okay, whenever you are suffering with acidosis, What kind of breathing you are going to have? Imagine if I am the person who is having diabetic ketoacidosis. Acidosis will influence the respiration. The patient is going to have hyperventilation, something like that. So this type of breathing pattern, okay, the hyperventilation is called as Kusumal's breathing. So simple. Kusumal's breathing is seen in diabetic ketoacidosis. What is Kusumal's breathing? Hyperventilation. Deep inspiration, deep expiration. Okay, it's because of the acidosis that you will study in your respiratory physiology. And so this acetone, it's also a keto acid, it's also a ketone body. It will cause sweet breath, smelling. Okay, if you stand near to a patient who is suffering with a DKA, diabetic ketoacidosis, you will feel the sweet smell because of acetone is there in his blood. Acetone is coming out of his lungs, so you are going to have a sweet smell from his body, and he is suffering with he's suffering with metabolic acidosis leading to hyperventilation called as a Kusumal's breathing. Okay, and not only that, so these patients, because of this acidosis, I'm not going in detail, but because of this acidosis and because of this, excessive urination, see, the patient is losing some important ions, especially the potassium. So that's why in diabetic ketoacidosis MCQ, the patient is going to have potassium disturbances. Because of excessive urination, the patient is losing some potassium. And because of this acidosis also, I'm not going detail why potassium abnormality is happening. But remember, in diabetic ketoacidosis, potassium disturbances are seen. Okay, here the explanation is there, but I don't want to go. It will take a lot of time. So now tell me, diabetic ketoacidosis patient is not having insulin. Whenever he is not having insulin, too much hyperglycemia, 500. Normally, your blood glucose and my blood glucose will be somewhere around 90, 100 milligrams per deciliter, 90, 100 or 120 maximum. But this patient is going to have 500 milligrams per deciliter. So much hyperglycemia, so much glucose filtered, so much urination. Dehydration, polyuria and polydipsia. Potassium disturbances. Kusumal breathing is seen. Sweet breath is seen. Metabolic acidosis. Okay, all these are diabetic ketoacidosis. Simple. Tell me, all these problems, why? Why is there all these problems? All these problems begin because of insulin deficiency. Okay, all these problems because of the insulin deficiency. So what is the treatment? The treatment for diabetic ketoacidosis is simple. Insulin injection. Simply give insulin injection, the patient is now all right. The patient is absolutely all right. So what is the drug of choice for diabetic ketoacidosis? It is insulin therapy along with the hydration with IV fluids. Okay, IV fluids. Because the dehydration is there, no? So you are giving the IV fluids and rehydrating the patient and giving the insulin. And the question which was asked in the FMGE exam is, what is the cause of death? Okay, what is the most common cause of death in a patient who is suffering with a diabetic ketoacidosis? I'm not going in detail, like that you will study in your medicine, and the reasons are also not that much clear. It is cerebral edema. Okay, cerebral edema. Okay, cerebral edema is the most common cause of death in DKA patients. That's a complication of the acidosis. That's a totally different thing. So the cause of death in diabetic ketoacidosis is cerebral edema. Treatment of diabetic ketoacidosis is insulin therapy and IV fluids. Okay, in diabetic ketoacidosis, what type of breathing pattern is seen? Hyperventilation or Kusumal's breathing. Answer. Okay, so is it clear? Watching from Almaty. Okay, I'm good. Yes, I'm good. So after this, what I should teach you? What else I should teach you? Now, let me talk you about growth hormone completed, thyroid hormones important points completed, insulin important points completed. Now, let me talk about the adrenal hormones. Next, 5-10 minutes, adrenal hormones. Now, adrenal gland is, it's divided into adrenal cortex. This is the adrenal cortex, and the central most region is called as the adrenal medulla. Adrenal cortex and adrenal medulla, right? Now, so this adrenal cortex, okay, it is divided into further how many zones? Zona glomerulosa, zona fasciculata, zona reticularis. Adrenal cortex. This adrenal cortex, it is further divided from outside to inside. It is divided into G, F, R. Zona glomerulosa, zona fasciculata, and zona reticularis. Okay. So zona glomerulosa, it produces mineralocorticoids. Example is aldosterone. Zona fasciculata, it produces a glucocorticoids. Example is cortisol. Glucocorticoid example is cortisol. And zona reticularis, it produces 6 corticoids, especially male 6 corticoids. Example is DHEAs, dihydroepiandrosterone sulfate. Dihydroepiandrosterone sulfate. Okay. So now tell me how many parts are there in the adrenal gland? There are 2 parts in the adrenal gland: adrenal cortex, adrenal medulla. Adrenal cortex is having GFR, zona glomerulosa, zona fasciculata, zona reticularis. Zona glomerulosa, look here, zona glomerulosa is producing aldosterone, zona fasciculata is producing cortisol, and zona reticularis is producing DHEAs, dihydroepiandrosterone sulfate. And adrenal medulla, look here. So in this adrenal medulla, the cells which are present, okay, which I am showing you, the cells which are present, these the cell names. The cell names are called as chromaffin cells. MCQ. The cells are called as the chromaffin cells. These chromaffin cells which are present in the adrenal medulla, they are producing what? They are producing the catecholamines, adrenaline and noradrenaline. Okay, so adrenaline and noradrenaline, which are nothing but the epinephrine, norepinephrine. So adrenaline, noradrenaline, they are produced. They are the catecholamines. These are called as the catecholamines because they have the catechol ring. So these catecholamines are produced by the chromaffin cells which are present in the adrenal medulla. Okay, now MCQs which you need to know in your especially for your exam point of view is aldosterone. Sir, aldosterone, where it is acting, sir? What is the function of aldosterone? Simple. Aldosterone is acting on nephrons. It is acting on the collecting tubules. It is acting on which cells? It is acting on principal cells. It is acting on principal cells. Now, simple one word. Sir, if aldosterone, if it is acting on the principal cell, what is happening? Sir, if aldosterone is acting on the principal cell, small change, the sodium, okay, small typing mistake, sodium is going to be reabsorbed from the urine. Sodium is reabsorbed. Potassium is secreted. Potassium is secreted and excreted. Okay. So what are the functions of the aldosterone? Simple. Aldosterone acting on the nephron. Which part? Collecting tubule. Which cell? Cell name called as a principal cell. When aldosterone is acting on the principal cell, sodium is reabsorbed. Potassium is secreted. Potassium is secreted, sir. But the same aldosterone, see, it is also acting on a cell called as intercalated cell. When aldosterone is acting on the intercalated cell, what is happening? The intercalated cells are excreting hydrogen ions or protons. Protons are getting excreted. So now you can say one thing. Aldosterone, mineralocorticoid. What are the functions? Sodium reabsorption in principal cells, potassium excretion in principal cells, and proton excretion in intercalated cells. Intercalated cells are IC cells. So these are the functions of aldosterone. This is the MCQ. What they will ask you. All of the following are the functions of the aldosterone except. So you should know these are the functions. Aldosterone, acting on nephrons, acting on collecting tubules, sodium reabsorption, potassium excretion, proton excretion. That's it. Now, look here. Yeah. See, this is adrenal gland. Okay. This is the medulla. Now, there is a tumor which is present over here. Imagine there is a tumor. Okay, there is a tumor. This is called as what? Adrenal adenoma. Adrenal adenoma. So what is this? This is adrenal adenoma. It's not a cancer, just a tumor. Now, do you know what this adrenal adenoma is producing? It is producing excessive amount of aldosterone. Okay, adrenal adenoma producing excessive amount of the aldosterone, sir. Okay. Now, what is the name of the syndrome called as? Sir, adrenal adenoma producing excessive amount of aldosterone. This syndrome name is called as Conn syndrome. Okay, the syndrome name is called as the Conn syndrome. Now, what they will ask you? Clinical features of Conn syndrome. So, can you tell me what are the clinical features of Conn syndrome? Simple. Aldosterone functions, you know. Just exaggerate them. Normal aldosterone helps in reabsorption of sodium. Now, in Conn syndrome, see, in Conn syndrome, too much amount of aldosterone is there. What will happen? Too much amount of sodium reabsorption. See, now the sodium Na plus, not N plus, Na plus. So increase sodium reabsorption. Whenever more and more sodium is being reabsorbed, the more salt in your body causing hypertension. Your mother knows. If you take more salt, it will cause hypertension. More salt reabsorption, hypertension. It's a Conn syndrome. More aldosterone. More aldosterone means more potassium excretion out of the body, causing hypokalemia. The blood levels of potassium goes down. The body levels of potassium goes down. Sir, Conn syndrome, excessive aldosterone. More and more protons will go out of the body. More and more protons, if they are going out of the body, that will cause alkalosis. Okay, not acidosis. protons, the acids are going out of the body. So there is alkalosis. So family exam, definitely I will ask you this. In Kahn syndrome, adrenal adenoma, what are the clinical features? The patient is going to suffer with hypertension, hypernatremia, more sodium is there in the blood, hypernatremia, hypokalemia with alkalosis. Hypokalemia with alkalosis. So these are the clinical features. Okay. Answer. So these are the points which I want you to know. So what is the treatment? Treatment for the Kahn syndrome is aldosterone antagonist. You can use the drugs like aldosterone antagonist like spironolactone. It's opposite to aldosterone. It antagonizes the aldosterone, but the side effect of the spironolactone is gynecomastia. Okay, gynecomastia is development of the breast tissue in the males. Okay, gynecomastia. And never ever forget this gynecomastia topic is also very, very important. Okay, why? Because from pharmacology point of view, they will ask you which drugs will cause gynecomastia. Okay, there are drugs called as the disco drugs. Digitalis, isoniazid, S for spironolactone, yes, C for cimetidine, and O for estrogens. Disco drugs. There are drugs called as the disco drugs which will cause gynecomastia. Okay, spironolactone also causes gynecomastia, development of the breast tissue in the male. Completed, sir. Now, after this, aldosterone completed, mineralocorticoid completed. Now, cortisol. Cortisol is what kind of drug? Sir, cortisol, it is glucocorticoid. You know about the cortisol, right? Excessive amount of cortisol will cause which syndrome? So can you tell me what is the syndrome? This patient is suffering with which syndrome, sir? He's looking like a lemon. He's looking like a lemon which is standing on the sticks. Lemon on stick appearance. The syndrome, can you tell me what is this appearance, sir? So lemon on stick appearance is seen in Cushing syndrome. This is the Cushing syndrome. Okay, watching from Nigeria. Great. Appreciated. Now, sir, actions of the cortisol. Okay, see, actions of the cortisol. First of all, let me tell you important things which you need to know for your exams. I don't want to go through the entire things. At least important functions of the cortisol. I was saying cortisol is a catabolic hormone, the major catabolic hormone. Catabolic hormone. Okay, cortisol is a major catabolic hormone. And cortisol, do you know what it will do? It increases the blood glucose. Simple, remember. It's a catabolic hormone. And it's also a stress hormone. It's a stress hormone, catabolic hormone. Okay, it increases the blood glucose levels. Watching from Nepal, great. So, carbohydrate metabolism, yes, it increases the blood glucose levels. It's a catabolic hormone, right? So, cortisol breaks down the glycogen, increases the blood glucose levels. So, cortisol is a catabolic hormone, causes proteolysis. Now, older proteins, whatever are there in the blood, okay, older proteins, whatever are there in the, not blood, whatever they're there in the body, they will be lysed. Okay, they will be lysed. What about the fats? It causes lipolysis. What about the immune system? What cortisol will do to the immune system? Immunoactivation or immunosuppression? Immunosuppression. This is the MCQ. Cortisol, what it will do to the blood cells? Cortisol, it decreases all the WBC except neutrophils. Neutrophils are elevated. Okay, neutrophil count is elevated. This is the MCQ. Neutrophilia. Cortisol will cause a neutrophilia. Cortisol also increases the RBC. Cortisol also increases the platelets. But all that other WBC will go down. Okay, so neutrophils levels will be increased and monocytes are also increased, but that's not the MCQ. Important point is the neutrophils. Neutrophils are elevated. Neutrophilia is seen because of cortisol. Okay, done. And in heart, cortisol increases the heart rate. Cortisol causes vasoconstriction, means increases the BP. Cortisol normally increases the BP. On bone, cortisol causes bone resorption. So why I am telling you the normal functions first is you should be able to think what are the abnormalities. On the other half, you should be able to tell me the abnormalities. Sir, in the connective tissue, the connective tissues are there, no, which are having a lot of collagen. Do you know what this cortisol will do? Breaks down collagen in the connective tissue. In the GI tract, increases the acid production. in the reproductive system inhibits the gonadotropin releasing hormones. Okay, the gonadotropin releasing hormones like FSH and LH levels are decreased because of this cortisol. Cortisol inhibits these things. In the skin, cortisol usually, okay, for example, for understanding purpose, let me tell you like this. Cortisol will causes the pigmentation. Now, sir, here I have taught you the normal things. Now, can you tell me what happens in cortisol excess if you are having excessive amount of cortisol in your blood? Too much cortisol in your blood. That condition is called as Cushing syndrome. Can you tell me what happens in Cushing syndrome? Too much cortisol will cause too much hyperglycemia leading to diabetes mellitus. Diabetes mellitus. Okay. So in diabetes mellitus, what happened to the blood glucose levels? The blood glucose levels are elevated. Okay. Whenever you are having too much amount of glucose, which hormone levels are elevated? Insulin. Okay, insulin. But continuously these insulin levels are elevated. Do you know what this insulin will do? This insulin will cause adipocyte hypertrophy. Okay, adipocyte hypertrophy. This insulin will stimulate the adipocyte hypertrophy. Because of this adipocyte hypertrophy, the patient will have, see, this kind of, like, because of the adipocyte hypertrophy, the patient will have centripetal obesity. The obesity is going to be there, especially in the central axial skeleton of the body. Then now if you see, the patient is having moon faces, adipocyte hypertrophy, moon faces. And like, he's also going to have this buffalo hump, adipocyte hypertrophy. Okay. So even here you can look, the patient is having obesity. Okay. This is. So now tell me, sir, in Cushing syndrome, the patient is going to suffer with, yes, diabetes mellitus, true. He is going to have high levels of glucose. This high levels of glucose will increase the levels of this insulin hormone. This insulin will cause too much insulin continuously, will cause adipocyte hypertrophy. So the patient is going to have centripetal obesity. Okay, the patient is going to have a centripetal obesity. Now, proteolysis, cortisol, too much cortisol will cause too much proteolysis. So what happened to the muscles? Broken down. Yeah. So that's the reason why if you look at the patient, see, if you look at this patient muscles, they're totally atrophied. The muscles are atrophied, especially the muscles in the extremities, they're gone. So he will say, sir, my muscles are weak. So there is myopathy. He will say the word, these proximal muscles, whenever I'm sitting, they are very much painful, sir. So proximal myopathy is going to be seen. That's the MCQ. Proximal myopathy is going to be there. Okay. And next, what else you need to know regarding the Cushing syndrome? Mainly, I have told you about the centripetal obesity, proximal myopathy. Just remember that one point. And what else? See, because of this too much amount of cortisol, the platelet count, RBC count are too much elevated in the blood. Okay, in the RBCs and the platelets are too much elevated in the Cushing syndrome patients. So there is hyperviscosity of the blood. Whenever blood is hyperviscous, cause hypercoagulation, that increases the risk of deep venous thrombosis, MCQ. So Cushing patients are at a risk of deep venous thrombosis because of the hypercoagulable nature of the blood. From where this hypercoagulable nature is coming? Because of the increased RBCs and increased platelets. Okay, this is the point which I want you to know. Next, Cushing syndrome patients, they are going to suffer with hypertension because of, cortisol normally causes the vasoconstriction and it increases the BP, maintains the vascular tone, maintains the BP. Cushing syndrome, too much cortisol, too much vasoconstriction, suffering with hypertension. Cushing syndrome patients are having excessive bone resorption leading to osteoporosis. Okay. So the patients are going to have excessive osteoporosis. Now what, Nabil, you are typing something? You have any doubt? The patients are going to have the excessive osteoporosis. Next, in the connective tissue, see, the collagen is getting broken down. Even your blood vessels are made up of collagen. So now, tell me, in Cushing syndrome, the collagen is getting broken down. So what about the blood vessels? Even for the small trauma, the blood vessels are going to break down and there will be internal bleeding. So the patient is going to have bleeding into the skin. Okay, that's the key point to identify. See, moon phases, buffalo hump, centripetal obesity, those kind of keywords they are stopped giving in their exam. So they will say the patient is having proximal myopathy. The patient is having bleeding into the skin like petechiae and purpura. Okay, the patient is going to have petechiae, purpura, or the skin bleeding. Skin bleeding is going to be there. And because of the loss of collagen, even from the skin is now so much stretching, causing abdominal striae. You can see here, because of the loss of collagen, the skin is too much getting stretched because of the centripetal obesity, leading to abdominal striae. Okay, so leading to abdominal striae. And because of excessive acid production will lead to peptic ulcer disease. Now, because of the excessive cortisol inhibiting the FSH and LH, LH, there are no cortisol inhibits the gonadotrophic releasing hormones. So the female, especially in female, the patient will suffer with amenorrhea. Male also, the spermatogenesis will be inhibited. The male will also suffer with infertility. Okay. Now MCQ. Cortisol, what I have taught you, cortisol helps in pigmentation, but too much cortisol, what it will do? So too much cortisol, it will cause a hyperpigmentation. This is the keyword. So right here, hyperpigmentation. These are the things which are going to be seen in a patient who is suffering with Cushing syndrome. So regarding Cushing syndrome, lemon on stick appearance, centripetal obesity, moon face, buffalo hump, okay, abdominal striae, leading into the skin, hyperpigmentation is going to be there. Like, blood levels of glucose will be elevated, hyperglycemia is going to be seen. Okay, all these are the important points about the Cushing syndrome. Okay, so with this Cushing syndrome, cortisol also completed. Okay, now one thing, this is very important, especially from the medicine point of view. This question was repeatedly tested. The next adrenal hormone which I am talking is, now you are having a tumor here where the tumor is there in the adrenal medulla. Okay, now the tumor is there where? In the adrenal medulla. The tumor of which cells? Chromaffin cells. Now, this condition, this tumor name is called as pheochromocytoma. Someone is asking, homeopathic medicine leads to Cushing syndromes? Yeah, maybe possibly. Like usually Cushing syndrome is iatrogenic in nature. Okay, Cushing syndrome, the most common cause of Cushing syndrome is iatrogenic nature. Like, for example, imagine I'm 30 years old, I'm 35 years old. Now I'm having body pains. I'm taking steroids. Steroids are the painkillers, no. So I'm taking steroids, dexamethasone. Steroid is acting like a cortisol. Cortisol is also steroid, no. So taking medicines, especially painkillers, especially steroids, they will cause Cushing syndrome. So most common cause of Cushing syndrome is iatrogenic, doctor induced. If you prescribe a patient, or if you inject patient so much cortisol, or so much steroids, steroids can cause Cushing syndrome. Okay, why? Because cortisol is a steroid, dexamethasone is also a steroid. Okay, but anyway, now let's come back to our topic. Now what I am discussing here is pheochromocytoma. There is a tumor where the tumor is in the adrenal medulla. This tumor is called as a pheochromocytoma. What it will produce? Excessive amount of adrenaline as well as noradrenaline. Okay, now what is pheochromocytoma? Tumor of adrenal medulla. What it is producing? Excessive amount of adrenaline, noradrenaline. What are the clinical features? Sir, this adrenaline, noradrenaline, they are sympathetic hormones. As the sympathetic hormones, yes, they do the sympathetic features. They cause the sympathetic features like hypertension, increased heart rate, headaches, profusion, sweating, profuse sweating, anxiety, weight loss, elevated blood sugar levels. All these are sympathetic symptoms, right? Tachycardia, high BP, sweating, hyperglycemia, all these things are the sympathetic features. So, pheochromocytoma, the patients are going to have sympathetic features, but that's not MCQ. How to identify? Yes, you can do MRI, but that kind of questions won't be asked. How to put the initial diagnosis with a simple test, just urine analysis. Same. Now imagine this patient is having, there is this one patient who is having pheochromocytoma. Okay, he is having what? He is having pheochromocytoma. So he is producing what? Excessive amount of adrenaline, noradrenaline. Do you know what this adrenaline, noradrenaline will do? Normally, adrenaline, noradrenaline, they will go to the liver. In the liver, they are broken down in you and me. Yeah, in you and me. Yes, adrenaline, noradrenaline, whatever are coming from the adrenal medulla, they will be broken down in the liver into substances called as metanephrines. metanephrines and vinyl mandelic acid, VMA, VAMA, vinyl mandelic acid and metanephrines. Normally in your urine and a normal patient's urine, this levels will be normal. But imagine the patient is having pheochromocytoma, he is having too much amount of adrenaline in the body, man. This too much amount of adrenaline and noradrenaline, yes, they will also go to the liver where they are getting metabolized. So whenever they are getting metabolized, what happened to the urinary metanephrine levels? They are elevated, and urinary vinyl mandelic acid levels, they are elevated. So that's the MCQ. Okay. So what are the diagnostic tests? So the diagnostic test for the pheochromocytoma, this condition, is measuring the metanephrine levels. This is the most sensitive test. Also, you can do the vinyl mandelic acid level test. Okay, so checking the vinyl mandelic acid levels and metanephrines, total metanephrines in the urine, checking metanephrines is the most sensitive test for the pheochromocytoma. This is the point which I want you to know for your exams. Okay, after this, what else I want you to know? Okay, what else I want you to know? My favorite topic. This is my favorite topic. Okay, so there is a condition called as congenital adrenal hyperplasia, CAH, congenital adrenal hyperplasia. So, how to understand this congenital adrenal hyperplasia in 5 minutes? Okay, 5 minutes, 5 important MCQs. Simple, sir. Normally, hypothalamus, what it will produce? It produces a hormone called as CRH, corticotropic releasing hormone. Sir, this corticotropic releasing hormone, it will come and act on anterior pituitary. So this anterior pituitary, now it will produce ACTH. Okay, so CRH helps in the production of ACTH. Sir, ACTH, where it will come? It will come and act. ACTH means adrenocorticotropic hormone. So this ACTH is coming and acting on the adrenal gland. Now see, in the adrenal gland, ACTH is stimulating the adrenal gland. So now the cortisol, whatever is there in the adrenal gland, the cortisol, sorry, not cortisol, the cholesterol, whatever is there in the adrenal gland, the cholesterol will be converted into pregnenolone, pregnenolone will be converted into 17-hydroxyprogesterone. All this is because of CRH. CRH stimulates ACTH, ACTH converts the cholesterol into pregnenolone, pregnenolone will be converted into 17-hydroxyprogesterone. So this 17-hydroxyprogesterone, now there are 100 molecules of 17-hydroxyprogesterone. Imagine. The 17 molecules of 17-hydroxyprogesterone, they can enter into 3 pathways. Either they can be converted into, yes, aldosterone, cortisol, androgens. Yes. So 33 molecules, they can enter into the pathway of aldosterone. 33 molecules will be converted into cortisol. 33 molecules will be converted into the androgens. Like 33. Like, in equal percentages. But point which I want you to know is, see, for the production of this mineralocorticoid, aldosterone, for the production of this glucocorticoid, cortisol, what do you need? You need to have this 21 hydroxylase and 11 beta hydroxylase. So 21 hydroxylase and 11 beta hydroxylase are needed for the production of a mineralocorticoid and glucocorticoid, but not 6-corticoid. Okay, so now tell me, CRH helps in production of ACTH. ACTH acts on the adrenal gland, converts cholesterol into 17-hydroxyprogesterone. The 17-hydroxyprogesterone is, at the end of the day, it's getting converted into aldosterone, cortisol, and androgens in the adrenal gland. Now, whenever you having enough amount of cortisol, this is the real hero. The main function of this ACTH, is production of cortisol. So once you have this cortisol, okay, see now what this cortisol is doing? Sir, cortisol is giving negative feedback. Okay, cortisol is giving negative feedback. Array, enough amount of cortisol is there. No need of further ACTH. Enough is enough. Okay, but now let me tell you, this is something normal physiology. Let me tell you what is the problem. In this congenital adrenal hyperplasia, I don't understand dopamine medical school. I'm not very good with the Hindi. CVS is already completed. We have started with the CVS only. We're done with the CVS only. Yes, this is not a complete detailed class. These are the revision classes, especially for the exam going batches. Okay, that's why I'm mainly concentrating on the important topics in a very limited period of time. Okay, now what I'm discussing now, see, this cortisol, it is giving the negative feedback, but Let me tell you the problem. So this problem that too happening in a female fetus. Okay. Now the female is there. She is in the intrauterine period. She is in the intrauterine period. Now, do you know what happens? So in this female, these enzymes are not present. These enzymes, 21 hydroxylase, 11 beta hydroxylase, these enzymes are not there. Now in this female fetus, tell me, if these enzymes are not there, now can she produce aldosterone cortisol? No, she cannot produce aldosterone cortisol. This female, like the embryo which is growing in the mother's womb, now this fetus cannot produce the cortisol as well as the aldosterone. Now tell me, whenever there is no cortisol, do you think negative feedback is there? Sir, negative feedback is not there. So now more and more ACTH is there. Now this ACTH is converting all the cholesterol into 17-hydroxyprogesterone. Now all the 17-hydroxyprogesterone, now it is entering into which pathway? Now it is entering into the pathway of androgens. All the 17-hydroxyprogesterone is now entering into the pathway of androgens. So now in this female fetus, so much androgens are there. Now do you know what these androgens will do? Now androgens will lead to the formation of male looking genitalia. Because of this androgens, now the labia majora and the labia minora in the female, the labia majora and the labia minora in this female fetus, now they are fused and now they are almost looking like a scrotum. The clitoris, because of this excessive androgens, the clitoris in the female, it is enlarged and it is almost looking like a penis. It's almost looking like a micro penis. So this is the problem in congenital adrenal hyperplasia. Now tell me, which sex is going to be affected mainly in congenital adrenal hyperplasia? See, it can affect both males and females. In males, it's not going to be a big problem. Why? Because if a male is having excessive androgens, not an issue. He might be having a bigger penis or he might be having precocious puberty, not a big problem. But if this congenital adrenal hyperplasia, if it happens in a female fetus, now she will have ambiguous genitalia or male looking genitalia. She is a female but looks like a male. So this condition will lead to this congenital adrenal hyperplasia. It will lead to female pseudo hermaphroditism. This is the MCQ. Okay, so congenital adrenal hyperplasia, yes, it's a female but looking like a male, falsely looking like a male. That's why pseudo hermaphroditism. Hermaphroditism means opposite sex. So female pseudo hermaphroditism. Can you tell me one reason? Congenital adrenal hyperplasia. Okay, now why this congenital adrenal hyperplasia? This congenital adrenal hyperplasia is because of deficiency of which enzymes? Because of the deficiency of 21 hydroxylase, the most common enzyme deficiency. This one, the most common enzyme deficiency is 21 hydroxylase deficiency. The second most common enzyme deficiency is 11 beta hydroxylase deficiency. Now tell me, how to put the diagnosis, sir? How to put the diagnosis? Now with one word, if you want to put the diagnosis with one word, the answer is this. Sir, in this female, in this female congenital adrenal hyperplasia female, now excessive amount of ACTH is there. True. This ACTH is converting all this cholesterol into 17 hydroxyprogesterone levels. So now if you look at the 17 hydroxyprogesterone levels in this female, they are elevated. And the 17 hydroxyprogesterone is now getting converted into androgens. So in a question, if you see this word, 17 hydroxyprogesterone levels are elevated in which condition? Congenital adrenal hyperplasia. That's a diagnosis done. Okay. Now other MCQs, other problems. Can you tell me what is her main problem in this congenital adrenal hyperplasia? Do you know what is her main problem? The main problem for this female, it is not the ambiguous genitalia. She doesn't even know, she's a baby. She doesn't even know what her sex is. That's not the main problem. The main problem is this female, she cannot produce aldosterone, she cannot produce cortisol. Okay, these things are not there in her body. When these steroids, these are the steroids, right? The mineralocorticoid and the glucocorticoid, these are the steroids. When the steroids are not there, she will die for sure. Okay, so what you need to do, the treatment as a treatment part, see, MCQ, this is the MCQ. Steroids are the lifelong treatment. What is the treatment for congenital adrenal hyperplasia? Lifelong steroids need to be given. You need to replace the aldosterone. Mineralocorticoid replacement, you have to give the fludrocortisone, and the glucocorticoid replacement or the cortisol replacement, you have to give it in the form of hydrocortisone. So fludrocortisone and hydrocortisone, these are the drug of choice for this female. MCQs. Okay, so these are the points which I want you to know. So with this is also completed. So congenital adrenal hyperplasia, the problem with the 21 hydroxylase deficiency also completed. Now the last topic in the endocrine physiology which I want you to know is This one, sir. The last topic which I want you to know is very, very important, especially from the gynecology point of view also, and pharmacology, gynecology as well as pharmacology point of view. It's integrated. Normally, let me ask you, what is the relationship between the estrogens? Okay, what is the relationship between the estrogens and osteoporosis? Okay, estrogens and the osteoporosis. Let me tell you, which is something normal. Okay, see, a reproductive age group female, reproductive age group female. Now she is having ovaries, right? Yes, sir. She is having ovaries. Now in her ovaries, what is there? Follicles are there. So many follicles are there. Growing follicles are there. So these growing follicles, what they will produce? The follicles, the growing follicles, the follicular cells are also called as the granulosa cells. So the granulosa cells. These granulosa cells, they are producing the estrogens. Okay, so reproductive age group female, she's having ovaries, and in her ovaries, enough amount of follicles are there. These growing follicles will produce the estrogens. Okay, this is one part of the story. Now let's look at this beautiful female with these bones. Okay, this is her bone. Okay, now in the bone, how many types of cells are there? So the major two types of cells are, one is osteoblast. This is the osteoblast. Okay, and one more type of cell is there, that's the osteoclast. Okay, now what is this? This is the osteoclasts. Now, what are the osteoblasts? Osteoblasts, they are bone forming cells. They help in bone formation. What are osteoclasts? They help in bone resorption. They help in bone resorption. One is bone formation, other is the bone resorption. Now, let me tell you, actually looking from the outside will look like, osteoblast is a good guy, osteoclast is a bad guy. We'll see something like this. Okay, but actually, osteoblast is a real villain. Osteoblast, yes, it do bone formation, but osteoblast, it produces a chemical, this red color chemical. Do you know what is the name of this red color chemical? It is called as a rank ligand. Okay, rank. It's producing a, the chemical media is called as a rank ligand. On the osteoclast, there are these receptors present. Do you know what is the name of this receptor? This is the rank receptor. This is the rank receptor. Now this rank ligand will come and bind with the rank receptor. Now rank receptors are activated. Now this is the time where this osteoclast is activated. Now it will do the bone resorption. So now tell me, osteoclastic activity is under the control of, okay, osteoclastic activity, it is under the control of osteoblast. Osteoblast will produce rank ligand. This rank ligand will produce, it will activate the rank receptor, and osteoclasts are activated, leading to the bone resorption. Right? Now, let me tell you, in a normal healthy female, reproductive age group female, do you know what happens? Sir, these estrogens, they are acting on the bone marrow stromal cells. Bone marrow stromal cells. Now the bone marrow stromal cells, this bone marrow stroma, the stroma of the bone marrow, they are producing a substance called as osteoprotegrins. Sir, osteoprotegrins are getting produced. Do you know what these osteoprotegrins are going to do? Sir, osteoprotegrins are like beautiful female. So this rank ligand, this guy, after looking at this osteoprotegrin, he is totally inhibited, sir. This osteoprotegrins, do you know what they will do? Osteoprotegrins inhibit the rank ligand. So now rank ligand is not available. Rank ligand is not available for the osteoclast. So now do you think osteoclast is activated? No, sir. Now osteoclast is not activated. Okay. Now look here. See, osteoclast is not activated. Now when the osteoclast, when it's not activated, now do you think it's happy? No, it's not happy. Sad. Now do you think bone resorption happens? Bone resorption is not happening. Bone breakdown is not happening. Okay. So all the healthy females, 20, 25, 30 years, 40 years, now they are having good ovary, good follicular count, good ovarian reserve is there, good follicles are there. They are producing the estrogens, and what these estrogens are doing? Estrogens acting on the bone marrow stromal cells, helping the production of osteoprotegrins. Osteoprotegrins inhibits the rank ligand. When the rank ligand is not available, the osteoclast is inhibited, not activated. But what happened during menopause? Tell me. What happens during menopause? eggs completed. In a simple way, in a simple terms, I am telling you, X means the follicles. No follicles. No follicles. When the follicles are not there, do you think estrogens are there? Estrogen production goes down. In menopause, female is not having estrogens. When the estrogens are not there, now tell me, do you think osteoprotectins will be there? Osteoprotectins are not there. After menopause, 55 years, no osteoprotectins. When osteoprotectins are not there, tell me what happens. When osteoprotectins are not there, now rank ligand, now it can go and bind with the rank receptor. Now it can go and bind with the rank receptor. Now osteoclasts are activated, bone resorption. So that's why in menopause, 55-year-old female, why she is saying like, I'm having body pain, joint pains, why I'm having fractures, all this is because she is not having estrogen. So one point I want you to know is estrogen is osteoprotective. After menopause, no estrogen, no osteoprotegrins, osteoclast activation leading to excessive bone resorption, leading to osteoporosis. Now, some MCQs which I want you to know is, sir, after menopause there is more osteoporosis, right? Osteoporosis and fractures. Which fractures are most common? Vertebral compression fractures. The vertebral fractures, especially the lumbar vertebral fractures. Lumbar vertebral compression fractures. Okay, lumbar vertebral compression fractures are most common fractures in menopause. That's an MCQ which I want you to know. What is the investigation? This is from the radiology actually. This is repeatedly asked. What is the investigation that you will do for osteoporosis? There is a scan which is called as a DEXA scan, dual energy X-ray absorptiometry. DEXA scan. DEXA scan is the scan done for bone mineral density. To estimate the bone mineral density, how much the dense bones are, how much the bones are good, how good the bones are. For estimating the bone mineral density, the scan which is done is the DEXA scan. Okay, done. And the last point which I want you to know is how to do the treatment. If imagine there is a female, now this female is having osteoporosis, menopause. Now she is having osteoporosis. What are the drug of choice for osteoporosis? MCQs. Very, very important MCQs. Though I am physiology, but I'm little integrating it. See, you need to kill the osteoclast now. Okay, you need to kill the osteoclast, inhibit the osteoclast, and the drug of choice is going to be bisphosphonates. Bisphosphonates, drugs like alendronate, zoledronate, ipandronate. Dronate, the drugs which ends with the name alendronate, zoledronate, ipandronate, pamidronate. These are the drugs which are coming under the family of bisphosphonates. They inhibit the osteoclast, they kill the osteoclast. So that what happens? Bone resorption decreases. When bone resorption decreases, that's good. Osteoporosis is getting under control, But the problem of this bisphosphonates is, as a severe complication, it causes osteonecrosis of the jaw. This is the MCQ. Okay, bisphosphonate side effect. This is the side effect. The side effect of bisphosphonates is osteonecrosis of the jaw. The one point which I want you to know. And other things, just I'm highlighting. Drug of choice for osteoporosis is bisphosphonates, and other drugs. Any other drugs can be used for the treatment of osteoporosis. Yes, raloxifene. It's like estrogen. So raloxifene is called as a selective estrogen receptor modulator. Yes, it is used in the treatment of osteoporosis. True. And drugs, teriparatide. It's like a parathyroid hormone. It's an analog of parathyroid hormone. Yes, it is used in the treatment of osteoporosis. And a drug called as a denosumab, MCQ. Denosumab, monoclonal. See, it's ending with the word mab. Mab means monoclonal antibody. It's an antibody. Do you know what this monoclonal antibody will do? It's like osteoprotectin. It acts like osteoprotectin. See, it inhibits the rank ligand. Okay, so denosumab is used in the treatment of osteoporosis. And last but not the least, the super drug which was tested many times in the exam is the strontium renalate. Strontium renalate is a one drug which will have two hands, I should say. With one hand, it will kill the osteoclast. With the other hand, it stimulates the osteoblast. So tell me one drug which will stimulate the bone formation as well as inhibit the bone resorption. It's the strontium renalate. So now tell me the kind of questions which will be asked in your exam is, which of the following drugs are used in the treatment of osteoporosis? All of the following are used except bisphosphonates are the drug of choice. SERMs like raloxifene. Raloxifene is a drug. It's a SERM, selective estrogen. It's an estrogen-like drug. So raloxifene is used in the treatment of osteoporosis. Teriparatide, strontium renalate, and which monoclonal antibody is used? Denosumab. Denosumab is a monoclonal antibody used in the treatment of osteoporosis. So with this, all the important endocrine topics are also done, completed. Okay. So now in the next class, Okay, I'm just trying to complete as much as possible, as many as possible. Hope that you like it. If you have any questions, you can ask me. Some Kiran, we are asking something. Does it happen with hysterectomy as well? What is hysterectomy? Like why, hysterectomy is removal of the uterus. Why you are trying to take it here? So does it happen with hysterectomy? What will happen with hysterectomy? Oh, osteoporosis. Okay, does osteoporosis happens with hysterectomy? See, hysterectomy is removal of the uterus. Oophorectomy is different. Oophorectomy is removal of the ovaries. During hysterectomy, uterus is removed, but ovaries are there, no? Removal of the ovaries is called as oophorectomy. Yes, if you remove the ovaries, for example, in a 20-year-old girl, if you remove ovaries, from where you can get the estrogen? Estrogens are not there, breast development will not happen. That will lead to osteoporosis. True, true, yes. Oophorectomy will cause. Okay. Hope you understand the things. Hope you like it. In the next class, the next session will be almost 3-4 hours session will be there. Most probably it will be in the day after tomorrow. In that class, the major systems are complete. These are the two major systems which will be integrated with the medicine also. So that's why it take a lot of time. In the next rapid revision session, it will be there for the next almost 4 hours session will be there. In that, we'll complete the entire rapid revision of the physiology. Hope you like the lecture. If you have any doubts, you can ask me. If not, then go and have your dinner. PDF will be shared in the group. Okay. Okay, guys. Bye bye. See you in the next session. Bye bye.